So good morning, everybody. Welcome to July's meeting, public meeting of the NHS Humber and North Yorkshire Integrated Care Board. Welcome to everybody in the room and everybody who is joining us online. Apologies if the room feels slightly chilly at the moment. You'll thank me for that later when it gets rather warm in this room. So we are dealing with some strange temperatures at the moment. So I hope everybody in the room and also kind of joining us is managing to kind of keep cool in this kind of extreme weather. So just a reminder, this is a public, this is a meeting in public, not a public meeting. So really happy for observation of today's meeting, but there will not be the opportunity to ask questions in the meeting, but we'll cover later the opportunity to submit questions to the board, which we can cover at future meetings. So just I suppose we'll kind of move on to kind of the welcomes. Just to kind of note that today, we have Jane and Anya both with us in their new roles within our organisational structure. So welcome to you both in a new capacity. So Anya as our Executive Director for Insight and Commissioning and Jane as our Executive Director for People and Organisational Effectiveness. So there's been a strange bit where you've been on the board with a vote, you've been on the board without a vote, you're now back on the board with a vote. So welcome back. It's been a long time. And I just want to go around and do some really quick introductions. So last meeting was Michelle Sademan's last meeting, taking the minutes. Carly has agreed to step in and do the minutes today. But just for, I'm really grateful for that. So thank you for agreeing. Okay. And I'm just going to go around some quick introductions around the room so you can orientate yourself. And hopefully I'll test you at lunchtime so you can remember the names. Okay, so if we start at the end of the table with you, Michelle.
Well, yeah, I'm Michelle Moran. I'm the partner member on behalf of the providers, but I'm also Chief Executive of Humber Teaching NHS Foundation Trust.
I'm Dean Royals, Non-Executive Director, and I chair the REMCOM.
Morning, everyone. I'm Michelle Carrington. I'm Director of Nursing in the ICB with responsibility for maternity, clinical commissioning, adult social care nursing, children, etc.
Okay, and that's not on your name badge because it would be too big.
Morning, Nigel Wells, Medical Director of the ICB.
Good morning, Rob Walsh, Non-Exec Director, Strategic Commissioning, and chairing the Strategic Commissioning Committee.
Morning, everybody. Bev Riley, Non-Executive Director, and I chair the Quality Committee. Good morning, Jane Adamson, Director of People and Organisational Effectiveness.
My name's Carly Dakin. I am Business Support for the ICB.
Super, lovely to have you here. I'm Jason Stamp. I'm the Chair of the ICB.
Teresa Fennick, Chief Executive of the ICB.
Liz Irving-Brown, Director of Finance of the ICB.
Sue Holden, Non-Exec Director of the ICB. I chair the Finance Performance Committee as well as acting as the SID.
Hi, Alex Sale, Director of Performance and Contract Delivery, Coordinator of Health and Family Care.
Morning, everyone. Anya Hasbrook, Director of Insights and Commissioning Strategy.
Morning, I'm Jo Pick. I'm the Non-Exec Director for Insights and Experience. I sit on the Strategic Commissioning and the Quality Committees. I'm also the ED and I rep for the board.
Morning, Alison Barker, Chief Exec for North Lincolnshire Council.
Hello, I'm Mike Napier, Director of Organisational Effectiveness and Board Secretary for the ICB.
Super. And we're joined online by Lynn. Welcome, Lynn. Do you want to quickly introduce yourself to the room?
Thank you. Lynn Simpson, Chief Exec from Humber Health Partnership, and here as a partner member for the Cute Trusts. I'm delighted to be here. Thank you, Jason.
Lovely. Thank you, Lynn. So just to remember all that. So just to kind of note apologies for today's meeting. We've got apologies from Katrine McGee, who is the Non-Exec Director for Audit and Governance, Amanda Stanford, who is the Interim Executive Director for Nursing, who is being represented by Michelle around the table today. Sean Jones, I can never remember Sean's title. It's the
Executive Director of Commissioning. Sorry, it's not just that, it's planning and
planning and performance.
That's right.
Yeah. So
for acute and mental health.
Yeah. So apologies from Sean, but Sean Boffey will be joining us later in the meeting to cover that off as well. And apologies from Dr. Zoe Norris, who is our primary care representative on behalf of the two local medical committees. So we are quorate and we are good to do business. So you've got in your packs a register of members' interest, just for information. So just a reminder that when you get new interest, they need to be recorded on that register. And actually, when you take interest off, you need to notify us it's no longer an interest, but it will remain on the register for 6 months afterwards, just for transparency. So just note that as well. And in terms of gifts and hospitality, that you've got a copy of the current version of the gifts and hospitality register, just for transparency and noting as well as a thought. So in terms of this particular meeting, we're going to look at the minutes of the last meeting in public, which was the 20th of May. You can cast your mind back. We'll go through for corrections and accuracy, and then we'll pick up the matters arising in the action list. So minutes of the 20th of May in public. So any amendments to pages 1, 2 and 3, 4 and 5, 6 and 7, 8 and 9, 10 and 11, 12 and 13. So are people happy for me to sign those minutes as a true and accurate record of the meeting on the 20th of May? Okay. And if we move to the matters arising, so matters arising that we've got here. So board committee terms of reference, I think, are coming today, Jane.
Yes, that's correct.
And the freedom to speak up report, I think we agreed, didn't we, Nigel, last time, that we would just do some revisions to the strategy, but very much it was rooted in the old world ICB rather than new world. And I think you're in the process of meeting, I think, with Dean as the non-exec director, and I think with Jane as well, just to look at the changes that we need to make. Is that one on track?
Yes.
Super. And we're expecting that one at the September board. Brilliant. Thank you. And just to cover off the declaration of interest in terms of this meeting as well. So there's a generic interest in item 11, which is the transition update for everybody around this table who is employed by the ICB, and that includes the chair and the non-exec directors. We're going to take 2 items this morning, one of which is the annual report from the collaborative with key providers, which is sitting with you now, Lynn. So we'll just declare an interest on behalf of you hosting the collaborative with key providers. And then also the similar one, the report in terms of the mental health collaborative. Michelle will note the fact that that kind of sits with you when you are part of that collaborative. So that doesn't preclude any kind of involvement in the discussion of those items, because it'd be hard to present them without you. But we'll just note the interests. Okay, so we've done the matters arising. So we're going to move on. So there is no any other business that's been notified for this meeting. And we're going to move on to questions from members of the public. And we have 2 questions that have been submitted via the questions portal. I'm going to take them. So Jane, you're going to take the first one. So the first question is a organisational change question. So do you want to cover that one off for us?
Would you like me to read the question out? Because everybody's got that in their pack.
Yes, please.
The public won't know what the question is. So the question was, in the light of significant staff departures from the ICB, in the main due to voluntary redundancy over the coming months, can the ICB board reassure the public that it has the skills and capacity to meet the organisation's statutory and non-statutory duties? The main areas of concern would be good governance and the handling of complaints. And in your packs for the board members, you've got a written response to that. And I can read the response out, but I'll probably talk to it more than read it out. So board members and probably people from the public will remember that we were given a national mandate back in March 25, I had to think back then, March 25, to reduce ICBs by circa 50%. And there was that then took a long time to come to fruition in terms of some of the funding streams that were attached to that. So it would be fair to say, I think, that for any of us that are working in ICBs and all our employees, this change process has been exceptionally challenging for all colleagues affected. However, we did have to do that. So we worked on our operating model. We took a very structured approach to that. We consulted appropriately with our union colleagues. And eventually by February this year, started to concluded that consultation and moved into a new operating model. And for that operating model, we built that from the ground up. So we didn't, some ICBs did just reduce by 50%. We didn't take that approach. We also set up, we were required to, and we did set up a transition committee, which reports into this board, which actually is where the detailed conversations happen around the challenges that are linked to that organisational change. And when we designed the model and developed the model, we took very great care over making sure that our statutory responsibilities were covered, but also that the non-statutory key responsibilities were covered. We were working to what was and still is an ICB blueprint, and there have been various changes to that blueprint, but no official change to that blueprint. So the transition committee is the committee that actually oversees the implementation. And I think if you've been at this board, you'll be used to me talking about the stages that we're going through and how we're approaching that change. So we, as part of that programme, we also opened up voluntary redundancy opportunities for people, and people had the, as I say, the opportunity to apply for that. We had quite a rigorous panel process that we used to determine whether we could release people on voluntary redundancy or not. And that was linked to both statutory responsibilities, but also the skills we needed to be able to run the model that we designed, implemented and consulted on. And we've done that in probably 3 different ways. So people that we knew we could release relatively quickly through that process were approved quite early on. But then as we've worked through the different stages, we've been able to release more people through voluntary redundancy, again, using that panel process and again, making sure we kept a very close and consistent eye on the skills that were needed to enable us to run the different functions that we've got. It hasn't been without its challenges or its difficulties. I think everybody would concur with that, and continues to be the case. And continues to be quite anxiety driven for people that work here. Some people that are already in positions, but also losing a lot of their colleagues that are leaving through voluntary redundancy, and others that still also don't know what their future holds for them yet. So I do need to recognise that in the response to this question. I think that's probably all I'd say at this point in response. I think that was quite comprehensive.
Okay, so that's really helpful. And I suppose I just kind of want to add that, you know, in designing the new structure for the organisation, I think Teresa and I have both been very clear that good governance is at the heart of any organisation. So actually ensuring that we have the right governance kind of in place is very important. And then the other bit around complaints, and I kind of think we are moving into an arena of strategic commissioning, which is heavily informed by insight. And I know that we see the data we get from complaints as being a key element in helping us kind of reflect on the service that we commission. So very much in terms of how complaints actually, kind of inform the rest of the organisation is incredibly important. And I think very much we will see a much more kind of transparent process of complaints data going through our quality committee, but then also being cited at the board as well. And I think that way we can look at themes and trends, and actually that we know that complaints as a part of the feedback loop, the insight loop, I know, Anya, is incredibly important in terms of our future commissioning. So thank you for that question. And for both of these questions, we will be publishing the questions and the responses on the website kind of from this meeting, and we will write to the individual people who've raised them with the response to their specific question. So that was the first question. So the second question, so there's going to be a double act in response to this second question, which is called in the pack delays with discharge from Scunthorpe Hospital, but I think it's probably not that. There's probably some more stuff that's in there as well. So I think it's going to be covered off, I think, by Alex and by Michelle. Who wants to go first? Michelle, do you want to go first with the CHC response? Then we'll go to Alex.
It might be helpful just to go through the 3 questions.
Let's go through the 3 questions and then fight it out amongst yourselves.
Thank you. Thanks very much. Thank you, Chair. So there are 3 components to this question, and it relates to a individual case around concerns around delays for discharge. But there's a number of components. The first question is, why have the board not established adequate systems for identifying responsibilities for CHC pathways for Scotter residents? And Michelle is going to talk to that in a moment. And then I will pick up the next 2 questions, which is, why have the board not established a strong relationship with local authorities, both Lincolnshire County Council and North Lincolnshire Council, to guarantee adequate care can be provided for Scotter residents And the second component is, why is there no alignment in definitions of care and care pathways between local authorities and ICBs operating across the same region to enable residents to receive appropriate levels of care? So I'll hand over to Michelle specifically to pick up the issue about NHS continuing healthcare.
Okay, Michelle.
Thank you, and thanks for the question. And I did sense there was a personal story that sat behind this set of questions. And what I would say is, if that individual wants to contact us for a further conversation, we're really open to that. CHC is a really complex thing, and it's a complex thing for people to understand. It's a national framework, and if you meet the national framework, you meet the national framework, and therefore your care needs are wholly covered by the NHS until your needs change, if your needs change. But we should only assess people for CHC once their condition is stable enough for that assessment to have taken place. So sometimes I think the perception is there are delays in CHC deciding whether somebody meets while somebody is still in hospital, and we shouldn't be assessing people in hospital. So there's always this period of time where patients are discharged to the right care environment at that time, and then when they're more settled, CHC will be assessed and made a decision on. So I think sometimes there is this perception of delay, but actually that's following the national framework. In terms of why haven't we sorted that out for Scotland patients? If they have a GP registration with Scotta, and Scotta is in our ICB, then they are our patients. But the services that would be provided universally will be commissioned from another ICB. So sometimes that can lead to some confusion around who is providing the care and how that care is being provided. But as Alex will come on to, we work really hard to make sure that patients don't see the seams in any of that. And we work together really closely with local authorities to make sure that the care provided. So I hope that that covers that off. And I'm really open to hearing more about this person, or if they want firm confirmation of some of those systems and processes.
And then just before we kind of move on to the next question, I kind of think, I'm right in thinking that the whole process around continuing healthcare is based around that relationship between the NHS and relevant kind of local authorities. So I think there are really strong relationships, in all of our 6 places, and this one in particular is kind of North Lincolnshire. And actually, that there is a joint way of working, which we've had from the start of the ICB, around how we actually together manage cases within continuing healthcare. So I think very much as we grow and develop, it's something that we build on. And I know that very much there's an appetite for a conversation around how we might look at continuing healthcare moving forward in partnership with our local authority colleagues, and that's for both Silver and Medal.
Yeah, and I think it's worth saying there is a very in-depth and thorough improvement plan and action plan around CHC. Yeah. Due to its complexity of coming together of 6 CCGs, 6 places, and there is still some work to do in that area. So sometimes there are some differences of how that is employed, and sometimes that can lead to a perception that we are approaching things differently. Yeah, brilliant. And that suppose leads us on, Alex, to the second part of the other 2 questions, which are about the opportunities for partnership working and kind of coordination across both health and social care. So that interface between the NHS and local authorities. So let's take it on from there.
Yes, thank you very much. And to Michelle's point, there should, for the patient, be a completely seamless transfer, even if we are working across boundaries, and we work really hard to do that. And I think there are 2 core components to that. Really well developed, strong strategic relationships across those boundaries to make sure that we are managing those communications. But we have a set of statutory responsibilities and frameworks and eligibility criteria that we make sure seamlessly manage across those boundary processes, whether that be across individual local authorities, NHS, ICB boundaries, etc. And that includes some of the really important operational arrangements that we have in place to do that. So if we look at discharge pathways, for example, there are really well-established integrated discharge arrangements through the establishment of the Integrated Discharge Hub, which means that where we have complex discharges for people who have complex needs, there is an individual multidisciplinary discharge meeting approach to how those people are managed. On that, we have representation across the patch, including from Lincolnshire County Council and all our colleagues in the Greater Lincolnshire and the ICB, to make sure that we are managing those pathway and boundaries effectively to be able to support those needs as well. And really strong escalation arrangements if we do have complex cases as well, to try and make sure that we can minimise delays wherever possible. But as Michelle's alluded to, there can be some real complexities in those cases, which means it does take time to be able to make sure we've got the right processes and packages to be able to do that. And I think the effectiveness of those arrangements is reflected in the systems, what we call no criteria to reside. So making sure that we are able to get people back out when they are ready to be discharged effectively, where we can demonstrate there is good performance in that area to be able to manage that as well. So the ICB is really committed to making sure that we are working very closely. We've got a really well-established process in that area to make sure that we are working effectively. We've got clear pathways, clear eligibility criteria that we apply to how we manage that, support that across pathways to make sure that that doesn't disadvantage people because of boundary-related issues as well. And again, very much encourage people to share any, as you say, positive or negative experiences and specific experiences. We'd be very happy to respond to those individually as they come up.
Thank you, Alex. So thank you very much for those two questions today. As I say, they will be published on the website, and we will be responding individually to people who have raised those questions. And actually, if there are further questions for the board to take in public, then please kind of use the mechanism on the website to ask the questions. Superb. So we're going to move on to a presentation. So thank you for everybody who's been here this morning for their photograph taken. So I'm going to welcome Scott, Katie and James. Come and join us at the table. It feels like you're miles away there. So you're here for the presentation around three biggest killers, which I think is probably a really key significant moment in terms of kind of nailing bodies that kind of sit across our geography. And remembering our geography takes us all the way from Whitby Abbey to the docks of kind of North East Lincolnshire. And I think we have known very much that our use of healthcare services is driven by health inequalities, and that there are certain pockets of our population where we see presentation because of the kind of the combination of health inequalities. And I think this piece of work builds on, and this board in previous incarnation has, you've shared with this board previously, the huge progress we've made around the Centre for Excellence around tobacco and around that real difference that we have made in terms of kind of tackling one of the three biggest killers. If that wasn't enough, you've turned to another two things that you want to turn our attention to. So it's not only smoking now, it's alcohol use and healthy foods. I suppose by way of kind of reference, Joe, you and I were at an event, end of last month in York, which was the launch of this strategy. And I think it was a really powerful event that kind of talked about the collective responsibility for what we can do in this area. And part of today is about sharing that with the wider board, not only getting the board's commitment, but I suppose starting to test you on. So you've given us a really, really compelling argument. And I suppose the push is now what the actions we're going to take to actually do some stuff around this, because it is in our gift. And that's not just the ICB, it's our partners, and it's about what we do next. So handing over to you, and then very much just to remind people being asked to endorse the strategy today, but then also kind of it's the board commitment, and I suppose the board's commitment and curiosity as to what you do next. Over to you.
Thanks. Thank you, Chair, and thank you everybody for having us here today. I'm going to do a very quick introduction. I'm going to hand over to Scott and Katie to introduce themselves and take you through this. They've been the architects of all of this, and a brilliant piece of work. There's some data in the presentation and in the strategy. I'm not going to go into any detail on population level data because I'm also conscious that you've got a development session with our chief analyst this afternoon. I really don't want to steal his thunder. So, but please take it on trust that we have people across our ICB who are generally living in deprived communities, which includes our coastal and port communities from Staithes down to Cleethorpes and all the way into Humber, who are dying prematurely of preventable diseases, more so than people living in our more affluent areas. And those people in those areas who are dying younger are developing those conditions, those preventable conditions earlier. So they're living a greater proportion of their lives in ill health, which has a massive burden on them as individuals, on the communities they live in, but also on the systems that they exist and they work in, they live in. The drivers of, and obviously that's an inequality. I apologise for laying out. Obviously, I know you understand that, but that's a significant inequality that we have an opportunity to influence and to address. The drivers of those diseases are part of this strategy. They're not the whole answer. Equitable access to high quality health services is a really important driver of health outcomes, but it's a small part of a much bigger problem, bigger challenge. And the three biggest killers, I think, is a strategy that helps us drive some of that forward. So I'm going to hand over to Scott and Kate. Let them introduce themselves, and then I'll come back to them. James.
Thank you very much, and thanks for the invite today. Katie's going to dash in a minute because she's presenting the TV campaign that we did around tobacco to all our stakeholders. We've had the independent evaluation back, so if Katie runs off, it's not because I've said anything. So I'm going to stand up because I struggle to say the three big killers sitting down. But if I can just introduce myself to start with. So I'm Scott Crosby. I'm the Associate Director for the Centre for Excellence. And we're a small team that was set up to really work on tobacco. Tobacco is our biggest driver of early death, disease, and health inequalities. And over the last 3 years, we've really reduced smoking prevalence by looking at a whole system, comprehensive approach to tobacco, working across our partners and our communities. And we're at a record low in terms of adult smoking prevalence. We're at a record low in youth uptake, and we're at a record low at smoking at the time of delivery. So we kind of know what to do when we sit down, but it takes us, all of us, to come together and do this. When you're up against big tobacco, which I have been over the last, I don't know how long, you have to have one voice. And you have to go into this really connected, because it is David and Goliath business in there. And there is some tactics in there which will probably astound you. So I'm going to move on to the first slide. So I'd just like to introduce you've got the strategy. We did launch the strategy, as Jason said. And this lays out our vision, and it lays out a roadmap, an evidence-based roadmap for the three biggest killers: tobacco, unhealthy food, and alcohol. So this is the first time in the UK that this has happened, and it's our ICB that's leading this piece of work. Strangely, this came around from an idea. I was presenting to a local college, and like you do with public health and prevention, I'm giving this description of public health, saying that it's like a river, and you've got people coming down the river and they're all swimming and needing your help, and you're picking them out of the river one by one, which is fine, but you get more and more people coming down needing help. So at what point do you go up the river and upstream and find out why the hell people are falling in the first place that you're picking up? And when I gave this analogy to these students, I got them to think about an analogy themselves. And the analogy that they came back with, saying, that's all well and good, Scott, but we love where we live, but it's really, really tricky to live a healthy life. When you start going up that river, the current starts to get stronger. There's debris that's coming down, and then you get some pollution that comes down, and you're in a swamp. It's very difficult to get out of that swamp. And all you do at the side is say, would you like some swimming lessons? Would you come on, swim a bit faster? And really, the environment is sucking the life out of our communities. So this gives me the idea of pulling the three big killers together in one single evidence-based document. That's the next slide, please, Emma. The stats are quite astounding when you look at them. The three big killers cause the most disease in our communities, and that's the leading drivers of cancer, cardiovascular disease, liver disease, and early death and inequality. The deaths, which I've just pulled out, are quite staggering. So we have around 3,800 deaths every year just from people using these products, these legal products. 3,800 deaths, that's an entire population of one of our market towns every single year lost because of these preventable causes. So when we look into that, that's 70 deaths a week that's caused by these three products. If you look at cancer alone from a preventable point of view, a third of cancers are preventable. And you look at the three killers, these are new stats from Cancer Research UK. Tobacco, we know, is unbelievably toxic product. 14% of all cancers are caused by tobacco, 2% from alcohol and 6%. So you've got around a quarter just with these three products causing the cancers in our communities. Next slide, please, Emma. And it's not just the physical side. If you look at mental health as well, these three products, which are actually looking at the three products, are dependence forming products. They're addictive products. They're highly engineered and modified by probably about 7 or 8 huge multi-international companies that have engineered these products over time to become more dependent. We know tobacco became more addictive after the Second World War when the market was there and the commercial elements started to grow and market. Flavors, sugars, anything to make them more palatable and more addictive. We've seen the same with alcohol, and now we're seeing the same with unhealthy food. Optimum design to make them more dependable, and you cannot stop eating these things. I can't anyway. So in terms of a mental health perspective, we know that not only are our communities with mental health issues more likely to consume more of these products, is that these products are actually causing mental health. So there is a relationship there going on, is that they are more likely to consume, more marketed to consume, but more likely as well. So for tobacco, for example, someone with mental health conditions is 3 times more likely to smoke than someone of the general population. Those with severe mental health consume 40% of tobacco in this country. So next slide, please. And it's not only that, but these when you take these risks, I'll call them risks in this slide. If you take these risks and look at individuals that are just doing one of those, that's bad enough. But we know that these products cluster. It's not, people just don't smoke, but they also drink. That goes hand in hand with smoking. And we can see that in some analysis that we've done here, which looks at the clustering of those. And what we do know is that it's not just a static relationship, that if you drink, smoke, are inactive, and drink alcohol as well, and obese, is that you are 4 times more likely to get diseases and die from these products. So it's a compound effect. Okay, next slide, please. As I say, we're up against big multi-internationals here, so we're going to have to act together and as one. And I've just taken some examples out of here. So ICOS here, this is a relatively new product. This is a product which has been brought onto the market by a tobacco multi-international. ICOS is what they say is a new generation. It's still tobacco, but it doesn't combust, that tobacco, which they've been trying to push through the regulations that are going through at the moment as a harm reduction method. It's still tobacco, And you see it's next to the sweet counter here. This is a nicotine pouch. You might have seen these as you've gone into the garage, little tins of highly coloured sweets with often comic style strips on them. These are nicotine pouches that you put under your lip. At the moment, you can give those out if they haven't got nicotine in. We've only just brought the regulations in, but and we've got further regulations coming in next year to protect some of the marketing of those. But this is happening at the moment. So next time you go and have a look at some of these and how they are marketed, because they are marketed to young people, which is just unacceptable by the sweets counter. IQOS here, again, that's similar to the heat not burn products. It is already illegal to advertise tobacco products, but the tobacco industry do it because they know that they're bigger than us, and our trading standards, even though I'm saying that that is illegal, we should be taking action, can't take action because these are just trying it on, because they've got a legal document which they say, oh, these products don't come under that, take us to court. And it's just impossible to get through. Other examples, you've got Johnny Walker here and Squid Games. You can see the alcohol, the relation that's building with young people's culture and the relationship that's going, and obviously others are self-explanatory. But two things that have come on to the market recently, buzz balls, heard of those? Alcohol buzz balls, have a look at those in shops. I mean, when I'm speaking to kids, they're saying, oh, they're wonderful. You know, they're a ready-mixed cocktail in a little ball, brightly coloured, that they can pick up very cheaply. And we've also had a nicotine pouch, which is called Energy Fizz. These are like your fizzy cola bottles. And if you rub the top, you can get the smell of them before you've even bought the tin. It's this that we're up against. But as I said, unless we work together in an evidence-based way, we will not touch any of this moving forward. So next slide, please. I won't spend too much time on this because I spend all day on it. But ultimately, when you look across and the evidence of the playbook that these multi-international use, it's the same playbook. You see it's all the time. And when you watch the front groups talking and protecting some of these industries, because very rarely you'll see these multi-internationals saying anything. They use front groups very, very cleverly, and some sort of industry so-called leaning think tanks to speak on their behalf. We came up with a sort of bingo card, and when you're listening to people like Forrest and the Institute of Economic Affairs and the Adam Smith Institute and some of the grassroots AstroTurf organisations that industry make up, just have a think, because they're exactly the same. They talk about job losses in their local areas. They talk about, come on, this is a really complex situation. So we need to think about it, and we need to be part of the solution. So we've got some ideas, and it should be down to us to sort that out. And we can do that voluntarily. How many times have you heard that? You've probably seen the stuff around social media this morning. What we need to do is just get into schools. I can tell you, just going into schools does not work. The tactic around tobacco, it just does not work. You have to change the adult world. Without changing the adult world, our next generation will not, will just fall into the same swamp.
Does this lead us, Scott, onto the roadmap? So I'm keen that we get to the point that says we understand the problem, and you've articulated that really well. So if we can move on to the roadmap bit, which is about action, because I can sense around the table that people are getting quite agitated around the story you're telling us, and understandably, because that's what you're designed to do. So I'm quite interested to know, because actually this is a strategy that isn't a strategy on its own, because there's a roadmap at the end, which is the cunning way which collectively we can do something about it. And I think it's based on the different approach you took through tobacco. So now you've got us agitated for a solution. What is the solution?
Okay, on to the next slide. On to the, if you just go through these slides. Okay, we've come up with the framework, and off that framework, we've got evidence-based actions in the strategy. And we have to do those together. What the golden rule is that you can't pick and choose. So you can't cherry pick, oh, we'll do that, and we'll do that, and we'll, you can't do that. You've got to do this systematically, and you've got to do it as a system. So that's what I'm asking today, Jason, is that from our point of view as a convener role within that system, and we've got a document which is led by, ourselves and our directors of public health, say something needs to happen, and we've laid that out very clearly in the strategy. But what we do need to do is, in general, we have to shift that environment. We can't have people, coming into our services, for COPD and for cancer services, and then going back out into the same environment, which is just mass consumed. We've got to change the norm. So this is what we've been doing in terms of Katie. You've seen the mass media around tobacco. That's mass motivation to quit. But it's not just motivation. It's reducing uptake in young people, talking about the harm, and saying that this is not the norm, and there's a different way of doing it. And of course, this is what we're really good at, is supporting individuals with their weight, supporting individuals to quit. But without these two, that bit won't work. So we have to work together on those. Okay, next slide, please. This is some of the stuff that we've been doing to complement our local authorities. We've had a number of mass media campaigns that's been driven by local people, local voices. We've been down to Parliament a number of times and taken our communities with us to tell that lived experience story, that this needs to change, please let it change. And it makes a huge difference when politicians are hearing the story from individuals within our community. And next slide, please. The one thing that I just wanted to just make sure that I articulate as well, that these products are very different. So even the playbook is the same, the proportionality of harm is very different. People have to eat. We know that in terms of the drinks industry, that brings in revenue and positives in there. Tobacco, I would argue, has nothing, brings nothing in at all. So it's just making sure that we're proportionate our responses, and that's what the strategy does. It's evidence-based and it's based on proportionality. Next slide, please. So what I'm asking for, Jason, is that we have strengthened partnerships across all our providers, across all our partners. We take this very seriously. In that strategy, we need to work out roles and responsibilities for who is going to take what forward within that strategy. But together, tell you what, you can make a difference. We've seen it with tobacco, and we can see it this way. It will reduce inequalities, but the leadership on this, we're going to have to be brave, have that leadership, and we're going to have to do it at scale and together.
Superb. And I think, before I open up, my reflection, I think, of your launch was that you deliberately made this a very crowded space. So you took this away from being the whole responsibility of public health to say, actually, everybody has something that can contribute to this. And that key conversation, I think, with local government is less about threats of public health who know this stuff. It's about the power of licensing. It's about the power of planning. It's about how we start to kind of think around the messaging that we do. And actually, I think what opened up for me, and I think I'm interested to know the board's feeling, is that the opportunity we have with neighbourhood health in particular and that prevention agenda, and how do we have conversations with communities about healthy food when, communities have said to me, we don't know how to cook. who don't know where to get healthy food from. But actually the opportunity we have, the golden opportunity, the golden moment, as I often talk about these days, is about what can we do within communities, which is about this. And the key bit I remember about the smoking campaign is we all knew the stats, and the stats made us uncomfortable. When you made that about people, and you showed us people that we knew, people sitting next to us, our next door neighbours, our family members, that kick was the drive to do something different. And that was a really, I think I said to you at the time, Katie, that was a really, really beautiful piece of work, because actually it made it incredibly real. You knew who those 64% of people were. So I think you are building on something, and I think there's a movement here. I guess my question is, the strategy is great, the roadmap is lovely, the strategy is very pink, but actually what next? Actually, how do we make sure the conversation we have in a year's time is, look at how far we've travelled, people recognise that this was a priority and this was everybody's business. Jo, was there anything you wanted to throw in before we open it? Because you and I were together in your...
I did. It was my first event as a NED, and I thoroughly enjoyed it. I left with a lot more insight, which was fantastic. So thank you to Scott and the team. I think one of the stories that were most, that resonated the most for me was, and I've totally forgotten the name of the organisation, so Scott will have to correct me. But yes, it was Bite Back. How did you know there were like 10 people there? Anyway, so Bite Back, we're talking about having worked with their local authorities because they'd gone into recreation centres, leisure centres, and the vending machines, really simple stuff, right? The vending machines that were in there were full of like sweet treats and high sugar drinks. So they've worked as a voluntary organisation with the local authorities and those leisure centres to just strip all that out. New providers, new suppliers of the vending machines, healthy food. And the kids that were engaged in that whole process, Bite Back's very much led by children, were just really impassioned by the work that they'd managed to do. So that just shows how when the whole system comes together, you can make a small difference. Well, those small differences all add up, and it was just really powerful. I wondered if, Chair, if it's okay with you, if Scott could just share about the journey in terms of continuing to communicate, because I think that's really important.
Yes.
There's going to be a lot more events like this where we share with our colleagues.
Yes, and I kind of think we can come on to that camp, Scott. I think we can come on to, because clearly this is something that now needs to be kind of rolled out. And I think the board commitment today is that we are committed to supporting the roads work, but I know there is a plan. Before we kind of move on to that, any other thoughts from people around this table who weren't with us in York? And it was very nice, wasn't it? It was very nice to think of in York. So I'm going to take, loads of hands. Oh my God, no. So let's go. I'll go around this way. So we're going to go. I'm going to write this down because I'll forget. We're going to go Bev, then we're going to go Michelle, then we're going to go Michelle, then we're going to go Des, then we're going to go Sue, then we're going to go Anya. I feel like an auctioneer. And the Angus Ainsworth from like the York Trust. So let's start with Bev.
Well, thank you. Some of that it is, as Jason said, it's really kind of riled you in terms of particularly those buzz things. Never heard of them. Just in terms of your case study on page 7, I can remember when Fresh and Balance were established, so I've been around a little bit. I guess the big thing for me is absolutely love it. It's just it's focused on the children, isn't it? It's absolutely what you said. It's getting in to the schools, and I just wondered if there's a version of this that could be an easy read for kids. Some secondary schools, it's
that's a good point.
So let's take all the questions and come back, because I think that's part of the plan, isn't it? Okay, Michelle.
This one?
Yes.
I was at the event too, and I left as angry as other people did around the table. And I was left with thinking, I'm not sure I've got the free will I thought I had, given the actions of these conglomerates. It really was quite profound. And the fact that, 2/3 of smoking cancers can be prevented was one of the, big take-home messages. But for me, it's that this shouldn't be separate, sitting over here, that it should absolutely be integrated into other things that we're doing.
Yeah.
So there is definitely, in terms of assurance for the board, synergy to the children's plan and the children's board. And Scott sits on the children's board too. So I think we just need to refresh that and have a look at whether the children's board can support this more. We've got rising levels of obesity, etc. So it's a real issue. So yeah, my thoughts is it shouldn't sit separately. We need to try and integrate it into them.
I think that's true. I think that figure for the number of children starting school already obese is absolutely staggering. So, Michelle.
Thank you. Great presentation. I remember the one from tobacco that you did as well with me. So really, really impressive stuff and really impressive. And I really do like the strategy. A couple of things. Obviously, I would say that we've got a very extensive addiction service. So obviously, if anything that we can link in relationship to that, obviously to stop people upstream is really helpful. And we're also doing a lot of work around the mental health field, because obviously you rightly mentioned that, because unfortunately we've done very little between us collectively as a system to reduce, the really surprising statistics of mental health service users dying 25 to 30 years sooner than everybody else, and people with learning disability dying 40 years sooner than everybody else. And when you look at the average age expectancy, it's slightly declining. That's the same from a mental health perspective. So anything that we can do in relation to targeting that, then if you want to contact me direct, I'm more than happy to have a look at that, and also how we can work with some of our services. I suppose the other one is a bit from Michelle's point, and the other Michelle is, for me, the strategy is great, the roadmap is good, but one of the things I think we'd probably need to more involve an ICB perspective is, well, what are we doing from an ICB perspective? And I couldn't get that through the document in relation to strategic commissioning. And I think it needs to be front and centre, to be honest. It's got the ICB on the full cover. It needs to be the front and centre of this is how we're strategically going to commission, rather than just repeat the commissioning that we've already done in order to meet the health inequalities piece that you rightly mentioned, but also some of these killers as well, because then that will help when we go on to our UEC targets and when we go on to our performance report. And we have to stick with it, because we tend to lose a bit of faith and a bit of confidence in the preventative piece. We keep going. And then the other one is this might come out as criticism. It's not meant to be a criticism. I think we just need to look at the public health grant, because I noticed all the directors of public health have signed up to the report, which is great. But for example, there have been some reductions across the patch in the public health grant, which this can really tackle. And I mean, this isn't a conflict of interest, as it just I was highlighting, we've had to reduce some of our services that would tackle some of this because of reductions in the public health grant. So that comes back to my former point about how are we as an ICB looking at the resources. I'm not saying we need more resources, because that's not necessarily the right answer. It's how do we reconfigure what we've got in order to support this agenda if we're serious about it. Because you mentioned the ICB might be the first in the country. Well, that's great, but what are the outcomes are we expecting? And that will really set us above other folk in relationship to this.
That's really helpful. I think both Michelles have touched on how this integrates into our core business rather than becoming something separate. And I think one of those answers to the question about resourcing is actually, if you take that integrated approach, it doesn't become the sole responsibility of a public health grant. And I think that's a really interesting kind of point. So we're going to move around to this side of the table. So hopefully, Scott, you're keeping all these in your brain. I've got them all together. Yes.
Thank you, and thank you for the presentation. And unfortunately, I wasn't at the launch, so hopefully I'm not covering ground here that was covered there. It's continuing on the theme of integration, but more on the lines of information sharing and what we're doing in the space of looking at where research is happening, for example, in universities. And I've seen work in universities where they're looking at postcodes and actually prevalence of obesity, where people can't access big shops and cheaper food, where their local food source is very expensive, sort of high street supermarket type things. And there's a direct correlation there around sort of that poverty lens and actually the sort of inversely proportionate level of obesity. And I think what I'm saying is a lot of this research exists and a lot of this information exists, but it's not in ICB land, it's elsewhere. And rather than reinvent the wheel, what are we doing to hook into that? And the charities that are sitting around that and sort of lever off the back of that to do that integration piece in our constrained resources, but there's a lot of work already happening so that we're not duplicating that, I guess, and levering off the back of that.
And when we come to Anya, if we can just touch on the data bit, because I know that the data platforms that we've been using have really done, I think some of what Des is kind of talking about in terms of the data we have about communities actually tells us where potentially we might target some of this, and actually we know where the risk factors are in specific pockets. And I think that is such a gift for neighbourhood health. That is an absolute gift. We now know more about people in a positive way because we are dragging data from everywhere to tell a story about people, not a story about data. And I think that is the really powerful thing with this. So we're going to go Sue, we're going to go to Anya, And then Scott, you're going to tell us exactly what we're going to do before we look at what you've asked us to do. So.
Thank you. I think it is important that we look at the interdependencies of the three biggest killers. I think the two things that really struck me is, first of all, there is an inherent tension. Because as an ICB, we have a responsibility now to commission differently. And the consequence of that will be that some of the commissioning decisions that are made mean that some of the previously commissioned services will need to change. So this is for long term. And sadly, we're in an environment nationally where a lot of the decisions are short term. So I think that there's a really important point for us in the committee that I chair, that we've got to be mindful of commissioning for longer term benefit and not just short term fix. That's the first point. And I think the second point I would like to make is that as an ICB, one of the things that we are able to do is look at how smaller providers that are more embedded in local communities actually are known and can be seen to have greater impact. And there's a decision that we took at our last commissioning committee, very much that looked at the fact that the way in which that service was provided involves more local vision and was subcontracted to smaller charitable organisations. So I think that there is something about how we join up, that the role of the ICB now is to commission for the future. And that will mean changes, and we've got to be brave enough to step into that space.
Okay, I think that's really helpful. I'll touch on my report about we went to Bridlington on Monday, the launch of something which I think does some of what you were talking about. So I think that sense of actually our opportunity here is much wider than the very traditional ways we've done this in the past. And actually that sense of, from this ICB, being the first to do this, I'm always proud to be first, but also I think probably open to the creativity and innovation that we can bring to this space rather than just doing what Norman's done. Because let's face it, it hasn't worked for 20 years that I've been around, and unless we do something different, it's not going to work. So Anya, last words before we go back to Scott.
Well, thank you, Chair, and thank you. Really helpful presentation. And like Des said, I also couldn't make the session, so it's been really, really helpful to have the update. Thank you. Just a number of sort of interrelated points. Agreeing totally with what other colleagues have said about the integration and really embedding, and to the Chair's point around neighbourhood, I think there's this is going to take place at neighbourhood level, isn't it? So I think there's something about particularly the integration with neighbourhood health, but also the wider partnership neighbourhood agenda, and particularly topical, if you like, because we've got the haircut event on Monday. I think there's also something about how, particularly to Sue's point, thinking about the strategic commissioning, but also understanding a bit more of the insight around what are some of the drivers that may be more directly related to health and care. And I was very minded of another very helpful recent report from Health Watch around alcohol drinking in older women. And some of the contributing factors there were around coping with menopause, coping with caring responsibilities. So some of these things feel as if they're more exacerbated, if you like, by some wider health and care issues. So I think doing that further unpacking as we do the embedding and sort of triangulation would be really helpful. I was really struck with your key point around environment, but I was also struck by thinking about environment in a slightly different way. And again, going back to neighbourhood and insight, and perhaps the behavioural potential difference between some of those three big killers. As you've articulated, smoking clearly is highly addictive. I think it's one of the most addictive substances. But I know from a lot of the community insight that we've done before, we hear a lot about actually, because the places that some of our people live, going back to James's original point, they're not necessarily hopeful places, if I can call it that. So actually, again, people use sometimes alcohol, fast food, even when they do know that going to the chicken shop is going to be worse than going home and trying to cook some pasta. it just gives them a little bit of a buzz. It cheers them up because their places they live are just not hopeful places, which goes back to the point around the wider neighbourhood piece. So I think really understanding more about the insight and the drivers and that sort of slightly different environmental context would be really helpful. And I guess finally you touched on it, not just around young people, but education is so key. And I'm not one of we all talk to many people in our communities, but one of the stories that never ever leaves me is when we were doing, I think it was actually the We Need to Talk engagement, and there was a wonderful woman that was really gleefully telling us how she'd made the right choice for her family by buying an apple pie from one of the supermarkets that offered them for £1 or so. And in her mind, that was a healthy choice because it had apples in it. And she just didn't understand that the pastry, the sugar, everything else completely was outweighing the benefit of the apples. But it's that piece around, it's not just the education for young people, it's the education right through, but particularly all goes back to neighbourhoods, and the data, as you said, Jason, of being really targeted and focused about how we understand and support particular communities.
Okay, and before we come to you, Scott, it would be remiss of me not to squeeze in Alison in terms of kind of local government, because actually I think there is so much here which is an opportunity for us in that space. So I'm going to squeeze you in, Alison.
Yeah, just really briefly. Have you got a content engagement plan around health and wellbeing boards, around how? I guess there is something here. What we're talking here is about that kind of wider neighbourhood piece. And it's really important to have that connectivity, because we can sit here, can't we, and have really good ideas, but actually it is really how do you take this into those communities and use that community leadership, use political leadership in terms of being able to support the agenda. So I guess it's just checking where you are in terms of that.
Okay, and I suppose that, and I think that's really important, because I think it's wider than the usual suspects, isn't it? Because I think this is that political engagement with elected members is incredibly important, because this is about planning and licensing, and this is about the wider.
Talked about trading standards.
Yeah.
So it's really important, I think, too.
So Scott, I'm going to come to you to respond to that, and I think in lots of ways there's so much there that we could spend ages kind of going around it. And then, Teresa, I'm going to come to you just so Michelle's challenge that I think Michelle beautifully threw down, which was, so what's the ICB going to do? I think is the right question. So I think I want to give Teresa a bit of time to think about the ICB bit. Can we come back on that? And then I want us to go to the recommendations, because I suspect this isn't the only time we talk about this. I would like to be able for us to touch points, to say, actually, how is this kind of looking? Actually, what's the progress? Because actually, this will take time. Sue's right. It's not short term. But actually, there is an opportunity here to say, actually, the approach we are taking together is the thing that you're asking us to do. So everything you've heard, Scott, what's your initial thoughts and around what the next rollout is going to be?
Well, on the 3 points, really, one around integration. I think that's really important in terms of that we make sure, working with Nigel and James and the directors, that we make sure that we're not siloed, that we're not talking to ourselves. We're not, we keep making ourselves angry, but we've got to make other people angry as well. The broader system that Alison talked about there, that's a key part of this. How do we start to build on that and into communities? We've kind of got a roadshow going from the initial launch, which will be our first.
That will go out to 6 places, won't it?
We'll go out 6 places. So we're starting just working with the local authorities and the DPH and their leads and so forth. Just think about, how do we get that into the health and wellbeing? How do we get that on the agenda? How do we get health and wellbeing signed up? How do we get the young people's in each of the place? So that's the next bit in terms of the wider. And then the other bit is about sort of being very clear in those roles and responsibilities as well, about who can do what and the biggest bang for our buck in terms of starting off that. So I think what we're talking about there with the ICB is what can the ICB do? But my challenge to local authorities is, what can you do? And then it's the bit there that we're talking about is then bringing that, making it, I need to make it real. At the moment, it's a strategy, and how do I get people on board and make it real is the third point.
And I suppose kind of like that approach with local authorities is about telling the story of North Lincolnshire, telling the story of York, isn't it? Because actually, what will get North Lincolnshire agitated is what this means for North Lincolnshire, and actually that will get the response, isn't it? So Teresa, thinking about ICB response.
So I'm just picking up on Michelle's comment and also actually Sue's in terms of the longer term benefit, not just a short term fix. Because it's not actually necessarily about the ICB response per se, because the first thing, the challenge of, the ICB's logo on the front page, it's not that the ICB is endorsing something that somebody else has done. The Centre for Excellence is the foundations of our ICB response as a strategic commissioner, building our framework for population health. I think that's that's the first bit. It's not a separate endorsement of something that somebody else is doing. I think it is as the framework for our strategic commissioning approach. It is about commissioning for the future, supporting the shift to prevention, hence the link to neighbourhood health. And Jason, I think when you talk about our Bridlington visit, I think hopefully you can shed some light on what that might mean and what that looks like, particularly the work of the Hinge that if we're looking at being able to cook, access to healthy foods, etc. I was also struck, however, by something. So many years ago, or when we were focusing on community services, and there was a phrase that was that's always stuck with me, and that's about every contact counts. And I think that's truer even today than possibly it was then. And so part of what we do need to do and develop is actually holding every provider, NHS provider of NHS commission services to account in terms of, so what are you doing, irrespective of how somebody accesses your services and comes into, being in front of you, if you like, what are you actually doing to support this and to support that prevention, even if that is signposting and support, identifying the right support back through, neighbourhood health opportunities. And before Alison came in, I think I was making the link. So every health and wellbeing board, every joint committee with our local authorities, where are we putting that challenge into? So I think that's one of the things that we've got to do in terms of as commissioners of those providers. Actually, how do we assess whether they're actually doing their bit as well? So thank you. I think it was really interesting, but I do want it to be seen as a bit of a movement as well. And I know that's what you what you want.
And everything is an opportunity. So Lynn, you want to come in?
Sorry, and I should have come in before Teresa summarised all of that. And mine is just a reflection. It was really interesting to listen to that. I think we do need to think very carefully about how some of the acute providers can play into this space and reinforce the messages. But the question was more, the reflection was more about how we evaluate some of the preventative work and ensure it continues, because there were many elements in the presentation, but it made me reflect on the educational side. And I was thinking about, when we used to have Sure Start and how effective that was in terms of training, teaching, reinforcing the positive messages. And then that went, and I know it was a governmental decision, but in terms of our local application, we need to be careful we don't do a stop-start on a variety of pieces, but we need some longevity to create the change. So it was just that reflection. Thank you.
I think that's really helpful, then, because sometimes it's difficult to evidence stuff that doesn't happen, isn't it? So how do you prove that intervention has stopped somebody having a stroke? So actually, there is a creativity in how we measure outcomes, presumably, Scott.
Yeah, I mean, it's always been notoriously difficult. This is why prevention, it's easy to do randomised control trials on an individual on an individual rather than a population. So, but there are things that you can do. There's obviously there is outcome data on population health, which is ultimately our outcome to reduce disease, isn't it, on terms of that? But also there's kind of things around sort of peer reviews and understanding what's happened across the system. So what we're saying is that this is a system action. So we're talking about very brief advice at scale. We're talking about opt-out for alcohol and for weight management, for smoking, in terms of getting that information at scale. Provider information, and we've talked about vending machines and food and making sure that there is good, healthy food on offer as well. We've got smoke-free hospitals coming in. So there's some big levers to come that they'll get us off the ground. But yeah, I think we can do things. It's been, as you said, Jason, it's been a bit more imaginative in terms of how those evaluate.
And I guess the advantage here is that we will be doing some of this stuff on that whole kind of how we commission and kind of measure differently. So in some ways, it aligns really well. Alignment and integration are the key words I've used all this week. So Jane's gestured at me. I'm going to, out of sheer generosity, I'm going to allow Jane a tiny little bit.
It was. Did you as well? Yeah.
Oh, would you like a tiny moment as well, Rob? Please.
Yeah.
All right. So Jane, so that makes sure even more tinier, Jane.
Tinier, yeah. It's just connecting the programmes of work that we've got that's on my mind. So your upstream comment, I absolutely agree with that, and I've thoroughly enjoyed listening to all of this. But we've also got programmes of work that are going on around getting people into work, and the biggest difference that work can actually make in terms of educating people on their choices. And we've got a programme board on that. So I think if I connect you into that, there'll be some creative things I think that we could do.
That'd be really helpful. Go on, Rob.
Thank you, Jason. So great stuff. Fully on board. But two sort of observations around realism from my perspective. One captured, I think, in terms of the scale of the challenge. So Mexico, England, pubs can stay open to 5 a.m. Monday morning. That's not a criticism of anybody who made that decision. That's a reflection of the culture that we're dealing with. Go and have a drink until 5 o'clock and enjoy the footy. And of course, there's more to come home for. It's coming home.
Want to get that in.
So
somebody visit that at the next board meeting.
There's something for me about leading by example, though. So I've experienced the NHS in a personal capacity in the last, and local government in my professional capacity in the last 3 or 4 months, doing work and/or visiting people who are unwell, and used vending machines, for example, and got myself a fully leaded Coke because I needed it, and a really good bag of Walkers because I needed them. And the fact is, as a system, as hospitals, as an ICB, as local authorities, are we making the first step in projecting what this is all about and leading by example? Simple, small thing that we can all do. Because I can go into most organisations that are represented around this room at the moment. I think I've even been into a GP practice somewhere recently, not in 5 of the 6 places, but 1 of the 6 places where I could have got myself a Coke. Yeah. So that sounds a bit crass. There's something about leading by example. Start to set the tone. But the scale of the challenge, England, Mexico, have a drink until 5 a.m. And with 2 mayors, 6 health and wellbeing boards, 6 council leaders,
3 mayors.
3 mayors, forgive me. There's an opportunity to get them all in the room. And I've been in many rooms in my time where we've all said these things and the intentions are absolutely well intended. You know, it's great stuff. It means a lot. But nailing things to the mast and coming back in 12 months' time and you telling us, Scott, actually, we're starting to make a difference because you did this, as opposed to it's great, we're going to make a change, because it's going to take more than us saying the right things in this room and this great document to make the change happen. I think it's tangible examples of where we've made a difference, where insight has led us to a particular outcome. Small, incremental, marginal gains, and this will take a long time. England, Mexico.
It's really helpful.
It's 19 years on the 1st of July since the smoke-free legislation came in. That shows you that it can shift. We got that over the line, and just shows how much culture that changed.
Yeah. But it took not, and I think the whole thing is about, it wasn't overnight, was it? It was not overnight. There was such resistance. I remember all those years ago. So, James, final word, and then move to some conclusions, some recommendations.
I think just coming back to the kind of strategic commissioning question that I think was picked up earlier. And I think Rob's just sort of articulated one of our opportunities. I absolutely agree. We should be getting our own house in order before we're pushing everybody else to and leading by example. How do we support our inpatient units to make sure that they change their vending suppliers? How do we, much like Joe described in terms of the schools, we've got an opportunity to put that into our strategic commissioning plans and those conversations, but also part of that strategic commissioning piece, really, we should be saying these are the outcomes we want to achieve. This is the resource, and here are your playmates. These are the people you need to work with. Play nicely with them and fix it for us, and trust. Okay. The evidence is there. We can push forward on this.
Okay, so just to kind of pull this together, and there's a series of things that the board's being asked to do. So I think one of them is that I have immense confidence, Katie, in terms of the comms that kind of sits around this and the engagement sits around it. And I kind of think there's an example around how that has really made a difference with tobacco. So I kind of think how that strategy becomes kind of infectious to everybody else, I think is really important. I think the offer of where does this go internally within the ICB? So where does it need to touch? Because it's everyone's responsibility. I think it's a really good one. So where do we signpost this, but how does this become part of everybody's thinking? There is something about in that roadshow kind of element with local government around really making sure that we maximise the opportunities for as creative and as wide a conversation as possible, and we don't limit it to health and wellbeing boards and health and care partnerships, because I think it's what opportunity we have, and actually that's the one place that brings together partners and how that kind of then starts to influence out locally. We're being asked to endorse the strategy, so I think what I've heard from the board is very supportive of the strategy and is keen to know where the heavy lifting kind of happens in terms of making strategy about action, not about nice words on a piece of paper. There is something about supporting the commitments. I think, what I've heard is these commitments are at the heart of what the ICB is here to do. We are here to improve the outcomes for our local population through our levers in terms of strategic commissioning, and very much kind of driven by the data and our understanding of populations, and that almost is a given. So that feels as though that's right. I think it is about how we work with partners around this table in other rooms. And I'm certainly thinking about, whilst we're moving away from a formal integrated care partnership arrangement, I think there is probably a partnership opportunity to bring together some people to have the conversation about what next. And I'm really interested in that stuff around how user voice influences what we do. Because the real power, wasn't it, of that presentation was about people taking responsibility to say we want to make a change and we want this to be different. And it wasn't politicians that were doing that, it was young people. And then I think the other bit is about Teresa's point around this has to be at the heart, so maximise the opportunities we have to enable health. So we saw a community shop the other day, didn't we?
We did.
What a massive opportunity to have a conversation about healthy eating when somebody's coming to a community shop, and a conversation about vaccinations and other things as well. So those opportunities are massive. They're what we want to kind of make them. But I think you've done a fantastic piece of work. And thank you for the healthiest buffet that I have had in a very long period of time. And I'm now thinking about the hula hoops that are in my bag behind me. So thank you guys for everything you do.
Just a governance question on the endorsement rather than approval. Are all the other partners also being asked to endorse it?
So I think that's the takeout that I suppose kind of goes outside this room. I think the board can endorse it on behalf of the board, but I kind of think similar endorsements, I think, from the organisations around the table as organisations and we're not in the room. I think that's probably really important as well. Okay.
Thank you very much.
Thank you very much indeed. Okay, so we're going to move on to okay, we move to governance items. This is you, Jane. So you've got a couple of things to do here.
I have, yeah. So thank you. And I think this is relatively straightforward, so we might pull a little bit of time back on this. So what you've got paper and then you've got two additional items. But to remind you, following implementation of the new ICB model, we're reviewing all of our governance arrangements. So you will get terms of reference coming to the boards between now and September. What you've got today is the update of the Remuneration Committee terms of reference, which is a fairly minor change. It's updated around the freedom of information elements. And then you've also got the new programme board that we've got around Breakthrough Work, Health and Skills Programme Board. They are new terms of reference. They've not been before. So I'll begin with those, I think, before I move on to the special roles. So you've been asked to ratify both of those. I don't know how much detail you would like me to go through, but I'm assuming people will have read them. I'm happy to pick up comments on them.
Yeah, and I suppose the other thing as well is I think based on the feedback, I think the really helpful feedback we had about terms of reference when we first presented that first cut of them, you'll notice that the layout is different, that the layout is kind of giving us purpose of the committee on the front page. And we aim, if you like, if this format works, we aim to use this format for every other piece of, because just to warn you, there's a raft of them coming for the next meeting in public, which are the other ones.
You can see which ones are coming in the paper.
Yeah, we'll tell you the ones that are just, and I know that each of you, chair of committee, we've been asking you to go back over your terms of reference and just kind of make any kind of final changes within that. And then the other bit is, I think the significant addition to all of them around the FOI, Jane, is actually that there is a consistent line in all of these. It's around freedom of information, which I think is incredibly important in terms of transparency. So, of those two, are people is the board happy to ratify those two terms of reference? Yeah. Okay. And actually, I hope it incorporates those changes that you were talking about soon, which was helpful. Thank you. So those are the terms of reference done. So your special roles.
Yeah, the second paper is for you to note, and we have responsibility for having a number of specialist roles in the ICB. Anya, I think we've got just the EPRR role still down for Sean, but that will become you. So as you note them, we'll also update that. But for the others, it is what you see. So it's got the role noted and then who's actually the person that's picking that up.
And just one comment from me, and it's only a typo. It says Senior Information Director for SID, and it should be independent.
Yeah. Okay. Yeah. Thank you. Well spotted.
Yeah.
Sure.
Well done.
Yeah.
Teresa.
Yeah, I just want to note that yesterday the National Quality Strategy was published, and within it, I've not read it all yet.
There's more roles.
No, well, there's a very specific role around quality. Which would naturally, given Amanda is responsible for quality assurance, would sit with Amanda. We can update that, but I just thought we should note it now.
And we will take an overview of the National Quality Strategy, which did arrive yesterday. We didn't have time to this board, but these are the roles, and actually the transparency is on our website. We'll make that correction in terms of your role now too, in terms of the senior independent director, and actually. There is a tendency that when more things come out, that there is a need to kind of allocate responsibility around the board table. So, but actually, some of that, just the process is about who the most logical person is, and the person who tends to be mentioned most in this is director of nursing. Director of nursing, do everything. But so if people are happy with that, with those amendments, we'll publish that on the website. So that just clarifies it. Okay. So on to my report. So I'm not going to dwell on huge amounts of this, apart from there's some really important bits. So I think I've covered off the welcome to our new executive director appointments. Also, congratulations, Rob, on your OBE.
Said that last time.
I know that was in private, so we are now trying publicly congratulating on your OBE here as well. We note the change in leadership at Region and the appointment of Sam Allen as the interim regional director, alongside her continuing role as the chief executive of North East and North Cumbria. And I think very much Region is still going through its own organisational change process. So I think we are in a very strange time across the whole of the NHS at the moment in terms of organisational change and transition. I touched on a little bit. Jane will talk in a moment around where we're up to in terms of our own process. But I think this is the point where we are starting to see people leaving the organisation, and actually. Some of those people have had very, very long service in the NHS. Some of those people have had, really long service, within the ICB. It's starting to feel very real, I think, for people that people are leaving in hopefully as positive way as possible. And I think it would be remiss not to say thank you to those people, wish them very, best wishes for how whatever happens next in their careers. But actually, it feels a very significant moment that we are standing up a new organisation, and actually it's an organisation that can only be where it is today because of what's gone before. And I am immensely grateful for everything that people have done, because actually that has given the foundations for the organisation that we are in the process of becoming. So thank you to all of those people. Teresa will pick up a little bit, I think, in public and private around the consultation around boundary change. So I just wanted to touch on the fact that we've had an opportunity through our conversations to kind of connect with our local authority leaders. We've had an opportunity to connect with their offices and our providers to have a really positive conversation. Whatever the outcome of this, the value they place on the NHS, the value they place on the work the ICB do, the value they place on the opportunities for partnership working, that focus on place, has actually been really heartwarming and reassuring to kind of hear. And I kind of think if there was ever a measure of how far this ICB has travelled, it's actually in what our partners say about us. So I'm actually grateful for the time and the opportunity that we've had around that. We've talked about three biggest killers. Teresa and I have been on a number of visits to our providers over the past couple of months. So we visited Michelle over at Humber, we visited Navigo, we visited CHCP. And these provider visits, I think, are really important for us because it's about being able to talk about new ICB, our priorities, new ways of working, but also find out more about what organisations deliver. And I kind of think it's a real privilege to hear people talk with great pride about the work they do. So we saw a marketplace showcase, Michelle, where I know Michelle's getting very impatient with me, but actually taking the time to understand the range of things that your organisation provides, Michelle, was absolutely fantastic. And all the way through around that, I was thinking neighbourhood health. So the opportunity we have with the assets we have is absolutely massive. And I'm really grateful for all the people who've kind of welcomed us into organisations and giving us their time to tell us about what they think about what works and doesn't work. And I think that is incredibly valuable. We've said very much our new structure is about relationship, the key relationship between commissioners and providers, which is a new relationship, and actually how providers help us shape what we commission. And actually my only plea is, and my plea for the ICB is, we are doing fantastic stuff, but we're not shouting enough and we're not shouting loud enough, and we need to really do that. I want to pick up on the event in Bridlington on Monday. And very much Bridlington has been identified as one of those sites as part of the Coastal Navigators Network, which kind of came out of a report that the medical director, Sir Chris Whitty, wrote a number of years ago now, which was about a particular challenge for coastal communities. And we have a huge number of kind of communities that, within our ICB geography on those coastal communities. We know there are areas of kind of key deprivation, areas that sometimes feel forgotten about because they are at the ends of the country, they're on the coast. Bridlington has been one of those sites for a community navigators network. And it was the launch of what they're calling the Live Well campus in Bridlington, which is some of it is about co-location of services in one building, but also in a very small space, the ability to navigate between the DWP, the local authority customer service centre, the food bank, GP surgery. So actually effectively neighbourhood health in action. And if you remember, our funding of neighbourhood health centres will contribute towards the maintaining of that single hub. A hub which I'm proud to say is managed by a VCS organisation called Hinge, which actually is able to offer a range of services to people in immensely important support services to Bridlington and some of our most deprived areas. To hear them talk with such pride about the work they've done in partnership, to hear their ideas about what they could do next, the opportunities they have to kind of grow and develop what they have as a model was really, really inspiring. Very much in terms of that approach they have taken is a neighbourhood health approach. So it hasn't been about new stuff, it's about what is going to make the biggest difference and the involvement of the community in shaping what they are delivering in Bridlington through one single building, and the will of people to make it happen across organisations is actually a model of kind of really, really good practice. And I know, led by Lord Patel, who kind of leads the Coastal Navigators Network stuff, I think I took great pride in being able to sit there when we were talking about data and say, we have an integrated data platform. And Lord Patel was like, this is absolutely amazing. I know about that. Well, because we don't shout loud enough and we don't shout often enough about the stuff that we are doing that is driving forward. So I want to say a huge thank you to everybody in Bridlington for the work that's kind of made this happen. It really was inspiring. And actually, very much as a model, we will hope to build on that in terms of Bridlington. And I go back to 6 months ago, somebody said to me, Bridlington has nothing. And actually my response to that today is actually Bridlington has absolutely nothing. It was just curious to find out what it had and then do something with it. So I don't know if you want to say anything about Bridlington.
Bridlington in general.
And we had Teresa didn't have it though because she was concerned about it. But I had Bridlington lobster, which I thought was eating mess, but
It did.
okay. So then any questions around that one? And Teresa's going to pick up on some of those things, but it's certainly been a busy couple of months. So which we're going to segue to you.
Yeah, absolutely. And in true form, I'm not going to start with my report. I'll pick my report up in a minute. What I do want to start with, however, is the critical incident that we had last week. So I'm sure most people know that on the 8th of July, there was a fire in the Springwood unit at Malton Hospital. And that unit is now severely damaged and inaccessible. The patient was evacuated from there, and also that facility is operated by Tube. Fitzwilliam Ward, that was next door to Springwood, had 15 patients and they needed to be evacuated into a school initially. And that facility is operated by Humber Teaching, so Michelle's organisation. I'm sure Michelle may want to add a few things to what I'm about to say. Excuse me. So those patients were initially evacuated to the school. The community really rallied around and supported and helped with that. And ultimately, those patients were transferred to Bridlington Care Unit because obviously they couldn't be taken back to that facility. Although I think that's repatriation is happening today after some repairs. Also, outpatient clinics and the UTC, the Urgent Treatment Centre, were initially affected. So it was a very significant incident. And obviously we will be doing some work now to understand obviously what happened, the response, what are the lessons that we can learn should we have another such incident. Now, fortunately, incidents like this are very rare. However, it is really important to note that firstly, the staff responded really, really well. The work that was coordinated across agencies, across providers. We've got to talk about the fire service who prevented such, the significant blaze actually causing more damage to other buildings on the Malton site. And I know that Fitzwilliam was damaged, but a significant protection, I think, was also achieved from the actions of the fire service. The community really rallied round. So, the response was amazing and we need to recognise that. But also a big thanks to the EPRR team and on call and the coordination, as I say, across all the stakeholders. So I don't know if there's anything more you want to say, Michelle?
No, again, just to thank, I think, from an ICB perspective, I've done an open letter, just that obviously all the partners really, I think, who worked really well. It was a Tube building that was at a fire next door to Malton Hospital, but actually when I say next door, it was within touching distance, to be honest, and our side of Fitzwilliam Ward has sustained some fire damage, so we still only got half of the unit open. There were 14 patients that we had very frail, actually very acutely ill, that we transferred to the school at first, and the school were fantastic. And then we transferred them. We managed to get them all together. There were going to be some site moves. We managed to get them all together with Bridlington, and now I went up to Bridlington over the weekend, and everything was really, and the patients were really confident with the staff, etc. We did open some community outpatient clinics in the UEC on Monday, but it wasn't fit in suitable conditions to transfer the patients. We had to check the water quality, the fire alarms, various other things. So the rest of the patients were transferred, 14 patients were transferred yesterday. So we're still slightly reduction in beds, but we'll hope to get that up soon. But if it had been windy, it would have been a disaster because the whole of the ward would have gone. But the police transferred, the community staff couldn't get their vehicles. The police actually were utilised and actually transported our community nurses to the visits in the afternoon. So everybody got seen that needed to get seen, and we cancelled a few clinics, but we've managed to put the patients in this week. So
by staff working over. So it's been a really, stressful time for staff. Some psychological supporting for our staff, and we still don't know the cause of the fire yet. The fire is still working through now.
Okay, I suppose the board recalls its thanks as well. I suppose I think it's been these things always test us, but actually I think we often do our best in times of extreme kind of crisis. So
Okay, so I'm going to my report then. Excuse me. I'll take the report as read. There are just a couple of things I do want to emphasise. So talking about the boundary alignment, just for the sake of more public really in terms of background, within the 10-year health plan published last year, there was a commitment to consider ICB boundaries and alignment, particularly with upper tier local authorities, but also some suggestion around mayoral combined authorities. So the two areas affected for us were parts of North Yorkshire that are not currently sitting within Humber and North Yorkshire ICB, a small population sitting within West Yorkshire ICB, and an even smaller population that's sitting within Lancashire and South Cumbria ICB. And the second area were the local authority areas of North Lincolnshire and North East Lincolnshire on the south bank of the Humber. As Jason said, we've had many meetings around to hear the views of our stakeholders, our local authorities, our mayors, our MPs, our providers, and we have submitted the response that had to be with NHS England yesterday. We will circulate the response to members of the board. It comes alongside a number of appendices where we've received formal written views from some of those stakeholders. We have included those as well as obviously referencing them within the report. But just to confirm, the ICB's position and recommendation is that there should be no change to current boundaries. We recognise the perceived strategic benefits, particularly around upper tier local authority alignment for North Yorkshire. But the issues around patient flow, so patients within those areas flow to hospitals within West Yorkshire. The neighbourhood health services are developed around supporting those pathways of care through to those hospitals, the clinical networks that are established within those environments. So on that basis, we have recommended that there's no change to that boundary, although we have obviously said that if the decision is that the coterminosity is the goal, we will obviously make that work. We will work with those communities, those current service providers. We will make it work for patients.
We can come on to that more, I think, in part. But
in terms of the local authorities south of the Humber, again, our recommendation is for no change to that boundary. And that's, if you like, the reverse reason. We have got embedded neighbourhood health, embedded patient flows. The flows are, across the North Bank, particularly for the tertiary services at Hull. There's the interdependencies of the hospitals on the North Bank and the South Bank. And there is also the really important feature when we're talking about the wider determinants of health. There's the important feature of the Humber as an economic entity, both North and South Bank. So our suggestion there is, our recommendation there is that, again, there should be no change in order to support all of those things that I've just identified. I won't say anything about the VCSE report. The link is there. It's really important. As you said, that we recognise the role that VCSE plays in our ICB, and that we have in recognising the importance of the role that they have. Like we put on money where our mouth is, and we've got a role specifically within the ICB in the new structure as we had in the old, but actually embeds that as a routine way of working.
And Gary is coming to the September board to present that report and that future ways of working in BCS. So I think that's really important. Clearly, it's a club that was so well led for a number of years.
Not blowing your own trumpet there, Jason, by any chance? Just the PCN pilot visit. So I think at the last board meeting, I talked about the neighbourhood health visit that we'd had by the national team, and they had assessed our readiness for delivery of neighbourhood health, and we received significant praise. And I think, you know, that we were able to portray a degree of confidence to them in terms of our ability to deliver our ambitions around neighbourhood health. But then on the 18th of June, we had a follow-up visit around the progress on our primary care networks. So, Alex, is there anything you want to say about that visit in particular, rather than me?
Thank you. So there's two components. We have four PCM pilots within our patch, which is a specific national initiative looking at how we can really deliver that enhanced primary care working. And we have regular visits, as Teresa alluded to look at the progress with the work around those pilots as well. So overarching feedback, it was a really strong culture of collaboration across organisations, because as well as the primary care dimension, we have all our hospital trusts in the room as well, talking about the interface, how we manage care across the interface between primary and secondary care. And we have fantastic attendance in the room from all sectors with a really strong level of commitment, visible commitment and enthusiasm for all of those leaders as well to deliver that pace of delivery that's been achieved through the programme. I will just give a couple of examples just to really bring it to life. And then again, as Teresa alluded to, the neighbourhood approach partnership working, which had already been assessed just sort of briefly prior to that as well. And the kind of tangible examples from a primary care perspective are around management of same day demand. That's been a key focus with each of the PCN pilots. Looking at the development of management integrated urgent care, digital triage, and some of our areas are now delivering 99.8% of urgent care reports in 48 hours. So you can really see the improvement in access. Just to give one tangible example, one of the PCNs involved in the pilots managed to reduce their call response times from 40 minutes to 4 minutes. So it's a really improved position from the public access element as well. So really positive feedback on the work that's been done across those pilots and across the wider system in terms of the airspace as well.
Thank you. The only thing I would add is that yesterday, I think we also got the primary care survey data. We'll bring that back to a future board, but again, some really positive results in that survey.
Let's know, very positive.
Very positive.
Very positive.
Yeah, lots of green. Yeah, lots of green.
Yeah, although it's surprising the one that wasn't as green as everything else was dentistry, but that was no surprise.
And actually on that point, we are seeing improving.
It's improving. Yeah.
Yeah, so really lots of green, and it would be really good to bring that back and talk about it.
Yeah, I think it would be really good.
So in terms of the ambulance service, ambulance sector league tables, I just want to offer the board congratulations to Yorkshire Ambulance Service for leading the way there. And just to note that they have now been put forward for the Advanced Foundation Trust pipeline. So I think we should send our congratulations to them. The only other thing I want to pick up is people may be wondering why I've signposted a major parliamentary debate on paediatric acute onset neuropsychiatric syndrome, PANS and PANDAS. And for those of us who've been with the ICB for a number of years, and everybody will be aware, we want to hear the voice of service users, of patients, or families, and through that, some time ago, we had a mum come to talk to us about what had happened, the experiences of her child with PANS. and offered her time to share the lessons of that and to share that with providers, because the experiences of her child were so poor and so significant. And that's largely because it hasn't been recognised. It's often mistaken for a mental health condition rather than effectively a physical health condition as a consequence of infection usually. And it is emerging evidence base that I think is going to be really important in that. But given that contribution that mum was prepared to make for us, it's something that we're keeping an eye on and making sure that we are picking up any work around that moving forward. And I think, no, sorry.
I wondered if you were going to do midwifery.
I'm going to do midwifery. Well, not I'm going to do midwifery,
yes.
obviously. But,
yes. Please don't put a board to get through.
Yes. So obvious people again will be aware of the publication of two really important documents: the Baroness Amos independent investigation into maternity and neonatal services, and also the Nottingham reviews completed by Donna Ockenden. So I think it's fair to say that they don't make very easy reading, do they, by any stretch of the imagination. But unfortunately, they're not the first reports of this nature. However, within that, in the areas of focus, so Jim Mackey, the Chief Exec for NHS England, has written to us all with a 10-point, a 10-point plan that's going to drive the work of the National Maternity and Neonatal Task Force, with a national action plan that will be due in December. And that includes the rollout of Martha's rule. And again, a bit of background, that is effectively giving the right and making it easy for relatives to get a second opinion when they're not happy, when they've got concerns about what's happening to their loved one. They've got ease of access to getting a second opinion. And the evidence base around Martha's rule is quite profound, actually, in terms of lives saved as a consequence of that second opinion. So that is now being rolled out across maternity services. There's just one area I do want to focus on, I think, again, for those that have been around this table a while, when we have looked historically at some of the CQC reports for some of our maternity services. One of the areas that came through really significantly of that was around the triage services for maternity. So an important message within this is that there'll now be a national maternity triage specification that all triage services must meet. That will give consistent national principles that should then strengthen, protect, and actually support both equitable access, but the pathways, making sure that those pathways, those early pregnancy pathways, especially, are joined up. Now, all provider boards have got to complete a board level audit against that specification within the next 3 months, and then have got to complete the improvement against that audit within the next 12 months. So that's something we obviously, as commissioners, we will be picking up through our contract review meetings. So that's
okay. And then just to confirm, so there's already a whole governance infrastructure that sits around maternity,
yes,
which reports into the Quality Committee, and very much that route into the board, and the assurances are coming by the Quality Committee. And I think, Beth, you and I have had a conversation around, if there are things that are alerts for the board, then it can come straight to the board around it. But actually, it's an area where I think the board's expressed its concern in the past, and it's, actually, this is an opportunity, I think, to kind of think about what we do next around maternity services. And actually, I kind of think there's a strong kind of infrastructure there that enables us to have conversations with the right people. So I know that's on your radar, Ben.
It's a significant gender item from the being on the searching.
Yeah, brilliant.
Because of one as we're not in payments, and then the gym back election. Yeah. When I got where to take it on.
Yes.
Yeah.
There's a lot of things coming out.
Yeah.
Obviously, with management as well.
Yeah. Brilliant. Okay. Any other questions for Teresa? We'll pick up on some of those things in part two of the meeting as well. Michelle.
Thanks, and thank you, Teresa, for remembering the story about Pants Panda that came through Eleanor and her mum Lauren. And I think what we've seen is, we can see major legislative change based on the power of patient stories, the non-stop commitment that families have to change that. And it is a shame that we constantly have that as a lever rather than it being service-led. But Lauren is really pleased with the major parliamentary debate. It might be worth us revisiting the question that we asked of the system about how they would respond should they have that presentation, because people were unable to give a really good experience, and still that is the case in some elements. That would be good. The second is to mention the Hillsborough law that passed through the Commons yesterday and will be law by autumn. In relation to maternity, what that does is basically compel people to comply with an inquiry and be open and honest about that. And so in relation to the Leeds inquiry that Donna Opperton has now moved, it's just us being really live to the fact that that might throw out some differences between Nottingham and Leeds, where a significant number of people chose for their own personal reasons not to partake in that. I think we've got a number, about 60 people. So we might see some differences there, but it's a very significant law that we'll have to come back to and have a discussion about.
Of course, we're moving towards parliamentary recess at the end of this week, and a potential, a definite change in Prime Minister and a potential new ministerial team. So I think we are in interesting times in terms of parliamentary business and what the new parliamentary session may hold with some different faces around tables. So, but we'll pick up some of this stuff as we kind of move forward. So, Jane, we're going to move on to transition. I think this is one where I think Teresa and I have danced around it in our reports already. So, stealing your thunder as always. There's the opportunity to have a more detailed conversation, I think, with them inside in the second part. But I think this is just that kind of public kind of oversight of where we are with what feels like has been a really complicated process that we'll get towards the end of, but we are still in the process of organisational change.
Yeah, we are definitely still in the process of implementing organisational change. We've had, and to remind people, particularly those who might be listening that weren't at previous board meetings, we're doing our organisational change, following our policy through 3 different stages, and one of those stages has 2 elements. So we've now successfully moved from stage 2A into stage 2B. 2B launched on the 6th of July and is in the process of individuals meeting with their managers to make decisions about whether any of the roles are suitable alternative employment, which would lead to them putting expressions of interest in. We've got 110 roles in this stage that we're working on now. It would be very remiss of me, though, not to say thank you to those of you that worked on stage 2A, very closely on stage 2A. There were 118 interviews over 30 days in stage 2A. That's absolutely significant. And the person who coordinated all of that was a lady called Angela Willis. So I would like to say a particular thank you to Angela. I'm sure that was very, very challenging on different days and in different weeks. And also to yourself, Alex, to Sean Jones, who's not with us today, and the HR teams and the independent panel members that joined those panels. It was a significant piece of work, fully completed apart from one person is doing a job trial to make sure that it is suitable alternative for them. So, as I say, we've moved on to stage 2B. So huge thanks to those that I've mentioned. Already been mentioned, we've got a lot of leavers in July, and we will begin to really feel that as people are leaving. By the end of July, we'll have had quite a number of voluntary redundancy leavers when I talk about leavers. We've also had a couple of other things to mention. Significant work going on around our governance arrangements linked to our new operating model with the collaborative leadership group working closely on that. And thank you to those of you that are on the collaborative leadership group. That's taking some work. Who would have thought we had 80 meetings? And that's really, it's bigger than that, really. Michelle, you would tell me that the minute I speak around some of the external meetings that are still not accounted for in that. And Mikey, thank you for leading that work, because
it's a team, to be fair.
It is a team. I know it's a team, but it's still a challenge to lead some of that. We also had the programmes, so our operating model is absolutely linked to our programmes of care, and we had a workshop for that at the beginning of July, which was a very positive workshop, and the people that came to that really helped us to understand our next steps around the programmes of care, which has led to us being able to, from the 1st of July, stand up, even though it's not in perfect form yet, stand up those programmes of care and help those of us that are supporting it around the perimeters to move it forward. So I think that's probably what I would say.
Superb. And we're going to come back to some more of this in more detail in part two. And I kind of think, you know, despite the fact that we are an organisation that is still going through organisational change, people are doing the most amazing stuff. I think to hear the enthusiasm around what we can do in that future strategic commissioning space is really, really kind of energising. And that very much, you know, the skills and talent that we bring from the former ICB into the new one, I think, and the huge amount of work, and, you know, to just add my thanks, the huge amount of work that goes on behind the scenes in terms of getting us to where we are now. That's the bit that we don't see. We don't see how you organise all of those interviews and all of those days and all of those conversations. We said that we were committed to doing this once and well. And I kind of think we have done it once. That's very sad that doing it well sometimes frustrates me because it takes time, but actually doing it well is the only way we can do this. So thank you to everybody. We'll pick up more on transition in the second part. So, Anya, we're going to pick up. So all the way through today, we've had a bit of a thread here, which is about the importance of patient voice and insight, and how actually the patient voice, however that comes in, if that's complaints, if that's engagement, if that's kind of the co-production opportunities, actually is the thing that really helps drive and makes commissioning strategic rather than transactional and tactical. So over to you in terms of the voice of lived experience. And reading this was sadly unsurprising.
Yes, thank you, Chair. And as members of the public and board members will know, this is a really important agenda item, as the Chair has just touched on, to really bring in the insight and intelligence from our patients, members of the public, service users around, you know, what they're experiencing and what's important to them. So you will know that we bring this every month when the board is in public, and particularly when there is newer insight to bring to the fore, which is why this is on the agenda today. So I will take the report, the pack as read, but I will just pull a few of the key points out, and then we have got in usual form a short film to really bring in the voices of some of our patients and service users, and then I will come on to what this then means for us, and particularly in our newer role as a strategic commissioner. So as you can see from the report, this focuses on the experiences of patient communication and administration, and I guess more some of the more administrative aspects of communication rather than the more general communication, although it does touch on both. And absolutely, we understand the importance in all aspects of our life, actually, around good communication and administration. But it becomes even more important when thinking about the health and care context, because usually people are in our system at moments that are quite unnerving for them, they're quite stressful for them, and so that exacerbates actually the importance of good and clear communication and administration to help them have a good experience and a good journey when using our services. So as you will see from the report, there is repeated local and national insight that really demonstrates that communication and administrative failures are among the most common causes of poor patient experience. And I think in itself, this is a really important point, because in some respects, it should therefore be easier to fix, because this is not a clinical intervention. It doesn't necessarily have to be a particular costly intervention. It could be something that is a little bit easier to address than some of the other challenges that we have. But absolutely, it should be noted that this is one of the most important points that contributes to poor patient experience. And as you touched on, Chair, I think what's more disappointing in particularly the latest national insight that's come out through the King's Fund is that remains widespread and worsening. We're not seeing an improved picture, which I think again is why it is here at board, because we need to be really cognizant of that. As you will see from the underpinning insight, and of course, some of this is fairly obvious, but these issues absolutely contribute to missed appointments, duplication, delays. Really importantly, they're a significant contributory factor to inequity of access and loss of confidence in services. And I'll come on to unpack that in a second, further in a second. And so how we flip that is that we absolutely need to see these issues through a quality, safety and equity lens, which again, I think is really important for this new board and the committees. We touched on the committees as to how we probably make some of this more explicit on our agendas rather than implicit as it possibly is now, but I'll come on to that a little bit later. And therefore, again, if we flip it, if we were able to make improvements in terms of communication administration, there is a significant opportunity to improve quality, productivity and patient outcomes. So before I move on to the film, I will just unpack a little bit further, because there are 4 key themes emerging from the insight, which really matters to us in Humber and North Yorkshire. So firstly, we absolutely know that communication drives people's perception of care. So patients judge the services not just by the clinical care, but how they're informed and supported. That absolutely is a key factor in how they feel. And likewise, poor communication and administration can affect their overall perception of the quality, if you like, of the NHS in general. So the two are very, very clearly linked. Obviously, administrative failures create waste. And again, we'll come on to it, some of this in terms of our performance.
Need the slides to move, Anya?
They don't necessarily need to, because I'm just pulling out the key points, and it's fine. As we've already touched on, those areas of waste include missed appointments, duplicate contacts, repeated information requests from patients, and staff spent time resolving avoidable issues. And so these are all really important points. We've touched on this many times actually in our Voice of Lived Experience, because it is so important, but I want to really stress the point again that the impact is not equal of this issue. People with long-term conditions, those experiencing financial hardship, language barriers, and where they need particular communication needs, experience greater difficulties, which again drives that further inequality and goes back to some of those quality and safety concerns that relate to this as well. And of course, and it was touched on actually in some of our previous agenda items, patients expect to experience the NHS as one system. They don't want to know about how we join up behind the scenes. So they expect information to flow seamlessly across organisations and services. And you will remember from previous insight that has been presented, that's one of the core frustrations that people feel. They need to tell their story, to personally share their information time and time again. So if we can just play the film, Emma, please, and then I'll come on to the considerations for Thank you. And as ever, I would like to thank the patients that have taken the time to share their story with us, because they are real stories that come from our network. So thank you to everybody involved in that. In your pack, you will see the final page, just some reflections and considerations. And as I say, I think this is really pertinent given where we are in terms of our sort of developing new operating model and role as a strategic commissioner. And I have to say, most of these things are probably implicit in our commissioning intentions and, you know, the agendas on our committees. And I think there's just something for us about thinking how we perhaps make them more explicit so that we can feel assured that we've got an improving picture. I'll just read them out for the purposes of the public and board. So the first is to make patient communication a system improvement priority. So how we might look to establish an improvement programme, particularly focused on this issue, probably embedded and aligned to one of our transformation programmes. And we've already got a one front door ambition. So how do we align that with the tell us once ambition again? And how do we make that happen? Absolutely fundamentally, how we improve equitable access. I will remind board members of the really, really powerful stories that we heard from our deaf community, which again absolutely showed how important this is around how we improve equitable access for some of our underserved communities. Accelerating digital communication, you remember the report last time around the NHS app, so that is moving forward, but how we continue to accelerate that, of course, for those that can use it while maintaining non-digital options for those who need them, and improve transparency for people waiting for care. That absolutely is within our commissioning intentions in planned care of how we improve communication for those on waiting lists, but again, how we elevate that so we see that at this board and across our committees. So thank you, Chair. That was all I wanted to.
Thank you. And I suppose everyone around this table has a similar story to the ones that were kind of being reflected by those voices, and I feel really grateful that they shared them. And I think this is the one thing that people talk about all the time. And actually, this is the bit simple thing that can make the biggest difference. So we've got Ben, and then we've got Alex, and then Dean.
Thanks. Very clear report, really easy to read. I read it yesterday and I was just nodding. And I would say in the last 6 months, I've got at least 10 examples of things happening. It's really absolutely amazing, as Jason said. It's been going on for a long time. And I guess for me, do we really understand the level of harm for people who are lost in the system, lost follow-up or lost in cyberspace? So that's a very, very big concern. The other element of that is we just found a lot of inefficiency in an ICB, in a system that we can't afford to have inefficiency. The insight on the deaf community is awful, and as is Chairperson as well. Fully support the use of commissioner leaders, but is that really going to do it? And how quickly can we see change?
Okay, we'll take the other views and come back on that, Anya. So Alex.
Yeah, I'm really heartened to see this, because I think we all know that often it's the experience that people have in the NHS rather than the clinical intervention, and such an important issue. And I think the point about how we really thread this through our commissioning intentions and ambition is key. We look at waiting lists. What does that mean for people who are on waiting lists in terms of their experiences? So really, the suggestion there around highlighting this around quality, safety and access and how we do that and thread it through all of the work we do, I think is really important. And on the focus that often what we measure is what we focus on, we might want to think about some of the very specific things that we measure within our approach here that look at not only the impact on productivity and efficiency, because if we get that bit right, we actually improve the experience for people at the end of it, because people are not having multiple handoffs, etc. So there are some things that we might want to think about measuring, but with a clear focus now around experience, as well as what does that mean for us in terms of weights and lists, etc. The two are absolutely interconnected.
I think it's worth remembering is that some organisations do this really well. And actually some organisations recognise the need to make improvements. So I kind of think there is something around none of this is new. And your shopping list, Anya, we are making progress in some of these areas. It's about how we accelerate, isn't it? So that move towards a single care record means that you tell the story once and it's all there and it's up to date. But actually, there is a way to go with that. But we have our opportunities, I suppose, as a commissioner. Dean and then Michelle.
Yeah, thank you for the sorts of insights. I just put one more, I think, onto the reflections and considerations, which is, as organisations go through sort of headcount reductions, there's a lot of focus on that on admin staff because it seems not frontline services. And clearly, there's a consequence of poor admin on that patient experiences as sort of highlighted here. So I think something else by way of a consideration. And then the other things look that appropriate to do. It would be good to see, we're going to pull those levers, when and what are the consequences by when of doing them. So on the, just take the bottom one, have all providers stand up to that, and then we'll be seeing sort of improvements from there. Because unlike the last presentation, these are some things, aren't they, that we should see a quicker improvements on if we do them consistently. So it's not a generational issue. It's a sort of year or 18 months, isn't it, for significant improvement, whereas the 3 big killers is a kind of generational sort of journey.
It's all within our gift to deliver, unlike the 3 big.
Yeah. Okay, Michelle.
Yes, actually, get a follow on from Dean, but we haven't had a conversation before. But
we're going to separate you next.
First of all, thanks for the presentation. It's really useful, and we've seen a few of these videos now. So I suppose my question is, well, so what is it? Again, it's a so what question constantly. People in my organisation will be aware of that. So what are we doing about it, etc. I did have a bit of an alarm when we mentioned measurements, to be fair, because I'll come back to that in a second. I think it's really important that we remember, again, that we are here as strategic commissioners. So there's a lot of things that are already happening in providers, and it's really great to see the stories and hear the stories, but I'm hoping those individuals have spoken to the organisations that they refer to, because the organisations can learn a lot from that.
Yeah.
And it picks up a bit your point, Jason, that providers do an awful lot in relationship to how we're trying to standardise our documentation, standardise our care, look at our communication structures. So I think the question these are helpful, but I think the question the RCB is doing is what are providers doing within their current contracted arrangements from the strategic commissioners in relationship to communicating with patients, and how are they trying to streamline it in relationship to that communication piece? Because we're all doing an awful lot of work, and we've got a lot more to do. I'm not saying that we've got it right. As you know, we have a declaration of interest. We're leading as an organisation, the NHS app delivers things, and we're also leading into WEAV, which is that shared hospital record. But that aside, it's how do we look at it wider? So the question for me is all these, but round up in one thing. Let's ask providers before we start to measure. We don't know what we need to measure yet, and we could just get into a whole forum of submitting data that is very, because all this is very operational. I think what I'm probably trying to say, but we're not very articulate, is quite operational, we're good, very helpful, but what we're doing is strategic. Strategic should be asking the providers, we give you so much within your contract, how are you minimising some of these, and where are your gaps, and where are your plans? That is more a relative question than trying to do some of this, because it's too operational.
Okay, and I'm going to come to Teresa in a minute, and then Nigel. So I think there is something about. I want us to hold on to. There is our role as the strategic commissioner, but then actually what's the opportunity we have alongside providers to actually find out more about what it is, how we learn from the best, and how we actually, there is a commitment in our approach across our system around patients. I think you're exactly right. We need to understand what we do before we can measure. There is something for me about experience of care should be about experience of care and not about, I didn't get a letter, I got 3 letters, because actually that's what people focus on. So that woman with the knee focused on the confusion, not actually what she could do once the knee was done. She didn't say, I can now do skiing, I can now do aerobics. It was, they messed this up because actually I was in pain for a huge amount of time. And actually there is something here about, I think we are starting from a positive position with this, but actually we don't have the mechanisms to have the conversation that goes, do you know, a simple thing that we might do might be more efficient, save money, but also ultimately improve our experience of care. So I'm going to go Teresa, then I'm going to go Lynn, then I'm going to go Nigel. Oh, and then Joe.
So just picking up on basically what gets measured, gets focused on. I have a great deal of sympathy with that because that's our experience, basically, everybody's experience. But I don't think they need to be different measures than stuff that we're already doing. So if we look at any complaints report from acute hospitals, you'd see those sorts of things in there. So I think there are probably already measures that are being collected that we can focus on. I also think that strategic commissioning as a concept, we are strategic commissioners, but what that means in practice, ultimately, when we draw it down, we have contracts with providers and we want them to deliver services, to deliver specific outcomes. And one of those outcomes is about patient experience.
It's measures now.
So we shouldn't lose sight of that as still being part of our core responsibilities.
Okay, that's very helpful. So Lynn, your thoughts on this?
Thank you. So I'm listening intently. I very much support what colleagues are saying. I think I was just going to build on what you were saying a little bit earlier, Chair, which was we really do need to get the learning out of this and that share and spread of good practice, because we hear the same things coming up time and time again. We hear it in our own organisation, we're hearing it collectively across the ICB. But how do we create that learning environment that enables us to tackle it? And then just a thought on that, I did wonder, there's the contractual route, which Teresa's outlined, and we can put stuff in contracts and organisations will respond. But is there something that's much more about a peer support and challenge process that would help us? Because I've often found those to be quite helpful. And if we take the approach that it's a support piece, so it's the learning bit, but you can bring the challenge in too. So if Michelle was doing that to me, or I was trying to do that with York and Scarborough, it would be on the basis of, we've heard this, these are the good things that we've done, but then I'd also be asking, so, what's stopping you from doing that? It's slightly different to the contractual route, which you could probably have both.
I think it's rich.
That's not me.
That's a strange noise there, Lynn. But I think the weightiness thing is really interesting, isn't it? Because actually, the reality is, when we look at the performance figures, there are waiting lists, and actually, people that comment about not knowing where you are in the queue. And actually, at least when he's trying to book tickets for a concert, he knows he's 56 in the queue, so he knows there are 56 people in front of him. I think there are some really simple things around what people say to me once about waiting lists is, I don't want to know where I am. I just want to know you haven't forgotten me. I still want to know I'm on the list, that you haven't suddenly dropped me off. So there is some really simple thing, that human interaction. And, and I'm not saying this is the same with other industries, but when I ordered some chairs, I was exhausted by the amount of progress I got about how the chairs were travelling from Norway. I knew every single bit of the route, but I knew the chairs were coming and I knew when it was going to happen. And however irritating it was, I kind of felt important that they were telling me this. And actually, I was reassured that actually it may be a bit delayed, but I still know they're on the way. So there is some, and I think that idea of where's the collective conversation around how we're doing some of this stuff and what's the learning and what can we do together, particularly where we've got complex cases where people are moving between organisations, because it's no longer the one organisation route, is it? This is about referring on, and does the referral get lost? I think there is something really tangible when you talk about there, then. Nigel and then Joe.
Thanks, Anya, for bringing this up again. I think as a strategic commissioner, we have power to push out on outpatient transformation and making sure that the patients get to the right place at the right time. A lot of the issues around this are failure demand, that people are bouncing around inappropriate clinics, wrong clinical models. And one of the ambitions that we have is around outpatient transformation, pushing out more advice and guidance, advice and refer models. So patients only and residents only go to clinics when they really need to. We also need to push out on the GIRFT recommendations about things like patient-initiated follow-up. So actually patients are in charge of their own conditions. So there's lots that we can do already that is out there that will help us. And the other thing that we can do, and it's great that Humber and Interweave are pushing on the shared care records, is we as a system and all providers in the system need to be able to make sure that they are sharing all of their data to the shared care record, because that's going to help patient journeys as well.
I think that's really important. There's huge opportunity with this, isn't it? So I'm gonna take Joe. I'm going to take Michelle really quickly, and then we need to move on to the collaborative kind of report. I suppose we need to get to the point where what we're going to do about Sanya, because I kind of think there is real support for this around this table, and I think there is a massive opportunity. I think in terms of some of the insights. So I would really hope that contracting levers are the last port of call, and that actually there is some stuff that we do together because it's the right thing to do, and it's going to be the biggest change that we can make for patients, that we want to do that together. So whilst I think there are levers around contracting and commissioning, there is also something here about.
So I absolutely agree with you, but I wouldn't use the words last resort. I would say they're the safety net, so they still.
So they're an option. They're an option in the box.
Well, they need to be there.
I think it's a good call.
Ultimate safety
Yeah,
net.
that's a good call. So clumsy use of words, but I suppose what I'm saying is that we should be able to do some stuff without.
Yeah. We shouldn't be dependent just on.
That shouldn't be the first place we go to, should it? I suppose what I'm saying. Joe.
So great report as always, and yet I suppose my commentary is, in this day and age, almost all administration is supported by some sort of technology. From a previous board meeting, my working assumption was that we don't do a lot other than the shared care on record to encourage standardisation of ancillary systems that sit around that. So, how patients book in GP surgeries or the letter production or any back office stuff. So whilst it should be a safety net, I agree that should be a term. I'm wondering if we can focus on some of that in the commissioning work that we do, because if we failed to date to encourage people to standardise systems where they can, then that will be where we need to. But it's such an integral part of every bit.
Yeah. Okay, so you take Michelle, and then we'll just look at what next, Anya. Yeah. Michelle.
Very quickly, I think all the things we've talked about, which might help fix some of these issues, are important. In the neighbourhood space, we mustn't not acknowledge the power of personal interaction, which helps people. So care coordination is hugely successful, really cheap, has massive impact on people to help them navigate all the different services and systems and processes. So we can contract for a model in neighbourhoods which includes care coordination, and we intend to do that without getting into the widgets of exactly what things need to be in the contract. The contract is at risk of becoming unusable in terms of everything getting stuck in the contract. So that personal support people, especially who haven't got digital literacy and who might not have technology access, etc., is really, really important.
And of course, we've got roles in those communities that are navigators, and certainly in terms of Bridlington, you have the ability for somebody to physically navigate you around the campus and to interpret the bit of paper in front of you as to what you need to do next. So, I mean, that's been a hugely positive kind of conversation around, and that real focus on experience, real focus on people being very understanding about pressure in the NHS and really understanding around the administrative burden there is there. And I think Dean's point is a really important one around actually what all those letters mean and communication means for people in organisations. Organisations are working really hard to kind of be much more efficient. There's almost the bit around we're not starting from a kind of an empty space. There's a lot of stuff here. It's just about how we actually move to the next level, isn't it? Anya.
So thank you, and I think there is something about taking on board what everybody said and maybe having something that where we can work through what that means, because I want to go back to Bev's really fair challenge of, what does this mean? And particularly, Lincoln, you touched on the really powerful work that we presented that we've done with the deaf community. And I raise it because I think it is the $1 million question, but also articulates why it should almost be easy, but it's not. So it actually needs us to really intentionally think about it and, taking on board what everybody said, because we had an internal meeting seeing where we've got to with the work from the deaf community. And I think what was, again, really, really stark there. So we're tracking through the Hull and East Riding Deaf Centre. Well, you'll remember that we did all of the work. It was much softer in terms of, empowering, our colleagues, our service users in terms of what they should be expecting, really reminding people of, again, the tools that are available. Unfortunately, we haven't seen anything come through in the insight from the Deaf and the Hull and East Riding Deaf Centre to say that anything has moved forward. Yeah. In fact, it looks as if it's widening and getting worse. We continually hear, that the services that are available in terms of translation and interpretation are not being used. They're not known. We hear about equipment being in cupboards, and it's not. Yeah. We all experience how powerful those stories from one group were, and how we all took it on as a bit of a call to arms. We're going to sort this out, but actually something's then falling down. It's not because people don't see the importance and genuinely want to do the right thing, but I just don't think it's an easy answer. So I would suggest we maybe take it away, and a number of us really work through that.
I think it'll be helpful. I think there's been a couple of really strong suggestions around the table around the actions that we might want to take next. Yeah. And I think Michelle's point around just finding out what we're doing already is the right starting place, isn't it? It's around, actually there's probably some absolute nuggets in here of gold that we just don't know, and actually it would be good to get hold of those. And very much this is part of our way of working. This is our relationship with communities and people who use our services moving forward, isn't it? It's very much driven by what people tell us is the insight that tells us we need to deliver. Okay, super.
Jason, just check the timeline on.
How long do you need, Andy, to do that?
You say this comes back every month. So will this be an update with the plan next month, or?
It's not. So usually it's a topic that comes rather than progress on a particular issue that's been raised.
Yeah. So I suppose what we could do is add an action onto the action standard that says in a couple of board meetings time, it's just kind of a touch base in terms of kind of progress.
Up to the next.
Exactly what I don't want to say is actually because this work actually won't actually complete itself within a given time frame. It's a start on a.
But we would want to see then what we have determined as you've
So let's have a touch point. I always get nervous of the word ongoing or continuous. So let's do a touch point in 2 months' time.
Can I just make a really small other point as well? Because I think there's something in what we do next is not only look at what we do well and what's happening, but how do we learn from other sectors? Because a number of colleagues have said, why is it that you know where you are when you're waiting on Ticketmaster, but you don't when you're on an NHS waiting list? There must be tools. It goes back to Joe's point. There must be tools or processes out there that we can pinch with pride, as it were.
And I also kind of say is it very much whilst I really support looking, I'm really interested in looking and doing. So the action is going to really important. Okay, so we're going to move on to the two kind of annual reports from two of our kind of collaboratives. So I'm going to come to Michelle first. So Michelle has declared an interest in this, and then I'm going to, and Mel as well. Hello.
Hello, how are you?
It's a very long time, Mel Brandry. One of us changed our hair. So we're going to go to Mel and Michelle kind of first of all, and then we're going to go to Lynn. So Michelle's declared an interest in this one as well. And just for, I suppose, benefit of people who've not been around this table until we moved into our new situation. One of the cornerstones, I think, in the previous ICB and one of our success stories was around how providers came together in collaborative arrangements.
If I may, Chair, because it's just.
I know you're going to talk about special, but I'm going to talk in general about collaboratives as well, because it kind of covers Lynn as well. So I didn't want to steal your thunder on that one. But very much that sense of collaboration across providers, and actually, in some ways, we will pick up on and it leads to the VCS one as well in a way, which is by bringing people together and providers together, we can make an actual significant difference. There is a difference with the specialised one, which is Michelle will kind of touch on, but very much I think it was the idea of collaboration driving our previous work, which is the stuff. And this is very much around, I suppose, kind of a finishing off of where we've been, particularly with the CAP one, where CAP goes next. This one is slightly different, but actually that whole sense of collaboration is critical to the same under. Okay. So tell us why this is different, Michelle.
Well, actually, I mean, Mel will go into Mel's the expert, but actually, as an organisation, we are actually commissioners. We've got a very large commissioning arm within our organisation, which Mel will go through. And at the moment, that reports into NHSE. So NHSE give us a budget. Obviously, there's some extra in relation to ICBs, but NHS give us a budget, just delegate it down, and we then go and we commission. And we've got a great partnership with various private providers and local providers and NHS providers, both within the ICB footprint and external to the ICB footprint. When we took on the, just very quickly, when we took on the budget, it was a huge deficit position. It was a massive risk. And the organisation was exceptionally wobbly. We tend to do it slightly different here because we've done all the aspects of commissioning in one bit, whereas in some other ICBs, it's split into different silos, which Mel will explain. But actually, since then, we've exhibited a very small surplus position by working together. And I think we do strategically commission. However, that said, Mel's the expert, so over to you.
I just wanted to say before anything was I really appreciate the opportunity to come today and share the highlights from our annual report. We do produce the document every year and we share it as part of, we produced it as a collaborative so that we can look through our journey and our achievements in the year, but also where we might want to learn and do better the following year, because right from the very beginning of the establishment of the collaborative, one thing we said was we need to show we've made a difference. We need to show we've made improvements to people's care and collaborative working. It is a specialised mental health, learning disability and autism collaborative. We don't use the word special just because we think we're special, even though I would say we are. We do it because the services we're responsible for handle the most complex, the most severe, that requires staff that are specifically trained in these areas, and patients are cared for in environments that are not general mental health environments. So I'm going to go through. Can't really see Emma, sorry, I need to just favour Emma. So, and
I suppose, Mel, everybody's had a copy of the report, so I think the highlighting.
I'm going to do the highlights, yeah. Yeah. So Michelle's absolutely correct.
We haven't.
Was the report not distributed?
No. Sent it last week.
Yes, I thought it was included in.
Put the slides.
The slide haven't been. So what I mean is you've all got the annual. So
we've all got the annual report.
Has everybody had sight of the annual report?
Yeah. Oh, I'm happy to send it to everybody because it's great.
We can send it again. We can send it again. So some people have read the annual report. Some people are hearing your highlights for the first time.
I shall tailor accordingly, Chair.
And I know very well that you'll be able to do that, Mel, without any thought.
Thanks. Okay, so Humber and North Yorkshire Specialised Provider Collaborative is a partnership, as Michelle said, of NHS and independent sector providers and a social enterprise. And actually, we're very unique compared to a lot of collaboratives in that we've got Navigo as a social enterprise within our collaborative. You'll see in there, we've got Leeds and York partnerships, as Michelle mentioned. Leeds are not within our geography, but they provide highly specialised services in our geography, adult secure and CAMS. And Stockton Hall, which is part of the Priory, which is one of the largest independent sector hospitals groups in the country. They provide services in York and medium secure unit. We established on October 2021. Before that, though, we went through 15 months of due diligence, going through the finance, the quality, the outcomes, the patient numbers, everything. So the benefits of the collaborative model, we can pull resources and expertise across the organisation. So we have an oversight group, we have a very clear governance structure. What is very unique within us, but what I think we've done particularly well is, Michelle's quite right, is Humber is the lead organisation in the collaborative and holds the contract with NHS England. But Humber has a very clear model where we are delineated. So the commissioning team and the provider arm of the organisation, there is a Chinese wall between us, although we all work together. We've reduced reliance on inpatient care. I'm going to come on to that in the presentation. We've used our savings to reinvest in alternatives to admission services. We've improved patient outcomes, and we can demonstrate that really clearly because we get that directly from the service users. And we've supported delivery of care close to home. I'm going to go in more detail as we go through. Thanks, Emma. Okay, so this slide, the key themes of our annual report this year were about how we've evidenced improving those patient outcomes, reducing health inequalities, expanding community-based and alternative admission to care, delivering financial sustainability, really key in a point of time in the NHS at the moment, and strengthening quality and safety. And as I say, I'll go on to that within the document, the presentation. So we have expanded alternatives to hospital admission, and we are providing more care for people who require highly complex specialised services in their homes than we were doing 4 years ago. We have improved patient flow. We have reduced delays. We have gone from 14 people clinically ready for discharge in adult secure to 3 people. That was done with over an 18-month period. We've strengthened whole pathway commissioning. So we look at why are people coming into hospital? How can we prevent them coming into hospital? What can we do differently? And we work really closely with the general and community mental health providers of learning disability, autism and mental health care in doing that. So we listen and we learn from each other. We've maintained strong quality oversight. I'm going to go on to that more in a minute. And we had a favourable end of year financial position. Impact obviously is just better for everybody, financial service user, everybody. Thanks, Emma. So this underpins everything we do. Co-production and engagement, and we don't do this as a tick box exercise, we do it properly. It was one of our foundations when we established that we were going to put the patient at the heart of everything. These are service users that we work with who have had significant trauma, abuse, neglect, and therefore it is so important that we do everything we can to ensure they have a voice, and we have lots of different mechanisms for doing that. One of them that we have is we have across South Yorkshire, West Yorkshire and Humber and North Yorkshire an involvement network, which is highly specialised involvement leads who are trained to work with people in highly specialised services. We have the big events. So last year we had a couple of events where over 150 people who access our services were able to come together. Now, understandably, we do have to apply to the Ministry of Justice on occasion when we're bringing some people together, but we do that in a structured and safe environment. And that's really important because on the day we have involvement workers there, there are people like me there, we have case managers, we have staff from the wards, and it's the opportunity of the people who use our services to come and speak to us. So in the summer event this year, I sat and had my lunch with 3 adult secure service users who were clearly telling me what they thought was great and what wasn't about services. And they know who I am. They're happy to come and approach me, which I think is real positive. We've rolled out the patient-reported enhanced measures. We've had 2 national lived experience awards. And we have very strong service user voice in everything that we design. So some of the services I'm going to come on to, we have actually gone and just widely met with groups of individuals, not just in hospital, people who've recently left hospital, or in the case of the young people, we've actually gone into doing some work with schools and education around what their friends have told them. So we try and get as much as we possibly can out of that. And this is the personal, it underpins everything we do, the little personal we have at the bottom. Okay. So tackling health inequalities. We've got, within all of our inpatient services, we have improved access to primary care and physical health services, including dentistry, although we haven't quite got dentistry right. We've still got a gap in one of our provision. But that's a big, huge step forward. 5 years ago, most of our service users in adult secure didn't have access to a dentist. I mean, that's just basic healthcare, isn't it? We've reduced inappropriate lengths of stay. We worked out this year that the average length of stay of a person in our adult secure services, either in Humber and North Yorkshire or out of area, is reduced by 380 bed days. That's the average length of stay is reduced by over a year. Fewer people receiving care out of area. So when we went live as a collaborative, NHS England used all national resources. We said right at the beginning, we needed people to be close to home where possible for local networks to enable step down from hospital, to enable them to be near their families, and then their neighbourhoods, their areas of support. So, for example, in Adult Secure, we have reduced, when we went live on the 1st of October, we had 181 adults in secure services. As at today, we have 139. That includes admissions discharge throughout the 5-year period. In 2024, April 2024, we had 18 children and young people out of area. As at today, we have 6. And the only reason they are out of area is because the services we do not physically have in Humber and North Yorkshire. So, for example, we don't have access to our own low secure children's service or a medium secure children's service. We have to use a regional resource to access that. We've got enhanced discharge escalation processes. So we work really, really closely with our ICB and local authority partners when we know somebody's ready for discharge from hospital. We start planning discharge from the moment they are admitted to services, which is something that wasn't done robustly previously. And we share with our local authority and our place neighbourhood commissioners and ICB every quarter a pack of information which details to them who from their area is in services and who within 6 months or less have been ready for transfer out of services. And we've done that ever since we went live as a collaborative to make it really transparent who was in. So it's not this out of sight, out of mind, it's everyone's responsibility. And we've got a greater focus on least restricted care. We've rolled out in partnership with the ICB, the HOPES model, which is reducing long-term segregation, particularly for people with learning disability. That's been incredibly well received by a lot of service users, and we've already started to see real positive outcomes from that. Thanks, Emma. Okay, quality assurance and safety. So within the collaborative planning and quality team, there's myself and there's 1.5 planning leads. But within the quality side, we have a clinical lead, we have an associate clinical lead, and we have 6 case managers, but 4 full-time equivalents. We take quality assurance really, really seriously. And what we found is by enhancing the quality oversight, that has driven the efficiencies in resources and use of resources. It underpins everything we do. We adhere to the national standard operating process for case management. We have over 97% compliance with 6 to 8 week patient reviews. So that is people being physically seen. We do have a service user in Scotland and we do have a service user in Wales. So rather than using NHS resources to jolly around the country, we've partnered with other specialised provider collaboratives who have service users in those units. We have a memorandum of understanding signed by the patient so they know it is, so that we can utilise their case management and our case management. So we share oversight to minimise NHS resources and people having to travel all the time. We've got a quality governance framework, which is strengthened. Just to advise, we do have an overarching governance framework for the collaborative. We've expanded oversight of community services and alternative admission. So we do visits to each of the services where our service users are placed for that patient visit, but we also do quality assurance visits to all our services twice a year, and they're done on deep dives into those services. We all providers, every single provider within the collaborative is currently on routine oversight and routine monitoring. But what we do is we do have the ability to use contractual levers when required for quality oversight, but it's more about that relationship. So we gather a lot of stock intelligence, we gather a lot of intelligence from service users, from advocates, and we utilise that to support our oversight. We also meet as a group of collaboratives of 40 specialised provider collaboratives. We all meet every 2 months and we go through what's happening in areas, what's happening, what's learning, what's brewing, what do we need to know about. Same with quality, the quality leads do the same. So one of the reasons for this mainly is obviously one of the main things we're concerned about is we don't want an Eden Fields on our doorstep. We all know what happened in Manchester, it was horrific. What was of interest though was when it did happen in Manchester, we were the first specialised provider collaborative NHS England National contacted to ask to go and support Manchester. So Michelle is aware, myself and colleagues from Humber and North Yorkshire, because NHS England have such assurance about quality oversight, we were asked to go and provide some support to Manchester at the time that they were going through Eden Field.
I suppose, Mal, so what the annual report talks about is that really outstanding kind of foundation we have in terms of the work that you've been doing. And actually that whole period of due diligence that was around the setup and then around all this, this assurance around quality and safety and things. So I know you're going to give us kind of a brief kind of like view of the services you provide. I suppose what the board is interested in is, so what next for you? You've got a really strong foundation in terms of delivering something which is nationally recognised, which actually is why you get the phone call that says, can you help out?
Yeah.
So I kind of think there is, and we'll make sure that if people around the table who haven't got the report, get a copy of the report. It is a really, really kind of inspirational read, I think, in terms of what we're doing with a very complex area of stuff. And the specialised nature means it is a small number of patients who are the most complex that we have to deal with, and the creativity with which you do that. So I guess, and just going to be quite conscious of time, it would be good just to touch on the range of services that sit in here, so we kind of almost kind of differentiate between mental health and the specialist bit. And then can we just make sure phones turned off in the room if it's actually for people to take it?
Yeah.
And then just kind of look at the what next bit, which I think is the really exciting bit. Yeah. Okay. So sorry to move you on that case, but
no, I'm aware of time, no problem. So one of the services we have responsibility for is inpatient adult eating disorder services. There used to be 2 units within Humber and North Yorkshire, the Shern Clinic in York, and we have Navigo, Raharian Fields at Navigo. The Shern Clinic chose to exit the market from provision of inpatient services in August last year, and they gave us 3.5 weeks notice. It was due to financial reasons that they decided to exit the market. I'm pleased to say we safely transferred all service users out of there, and we did that in full engagement with the service users and their families. What is really important, though, I think, is to know that because of the work of the collaborative, and because Leeds York Partnership, yes, they provide adult secure, and yes, they provide CAMS, but they were the first hospital we phoned up and said, have you got any capacity? And they were like, absolutely, you can have it at Humber and North Yorkshire because we work with you. We spoke with service users, they were happy for it to move there. Raharian Fields was able to flex its bed base from 5 to 8 very, very quickly. They were able to mobilise really quickly because of that flexibility we have as a collaborative. We approached Tees Weir Valley, but at the time we didn't have anybody at the top end of the patch who needed to go geographically there. So, but Chew straight away, absolutely, how can we help you? Which was really.
I visited Raharian Fields last week, and I have to say it was hugely impressive.
Yeah. So, and Raharian also gets all the time visited by lots of collaboratives from around the country and lots of eating disorder services, so that people can learn from what they do. Because what Raharian also does is it has a successful alternative to admission pathway. It's not just about inpatient. So, for example, we had a young lady on the inpatient service who had severely complex autism and eating disorder. To go on an inpatient unit for eating disorders is really, it's not ideal for somebody with autism, but at the time it was the safest place to provide care. As soon as the service was operational, engagement had happened with that young lady before the service was operational to say, this is an offer for you. That person agreed to go, and literally on the day the service went operational was discharged from Raharian. So it prevented a long admission because we had that service. We are currently undertaking a procurement exercise to expand the provision into North Yorkshire and York. I'm pleased to say we only have 6 people with an adult eating disorder in services as at today. We used to have average around 12, we're down to 6 because of the alternatives to admission work we've done. But we're currently undertaking a more suitable provider as part of the provider selection regime for North Yorkshire and York, so we can develop that service there as well, because we're acutely aware of some of the pressures in North Yorkshire and York. We have low out of area placements. We only ever at any time have 1. And if it is, it tends to be because it's an NHS member of staff who can't go to Raharian. It's as simple as that. We have no delayed discharges in adult eating disorder care. And if people aren't aware, FREED is the early intervention model for adult eating disorders. It's based on the model developed by the Bethlehem and Maudsley. We were one of the first in the country to roll it out. We were one of the few specialised provider collaboratives that funds it and rolled it out across the patch. We were one of the Bethlehem and Maudsley again approached us, asked us if we would do the work because of their knowledge and links with our clinical lead, Dr. Nicola Green, and we rolled it out really early across Humberside. We've had the service across Humberside for 4 years, and we're in the process of rolling out in North Yorkshire and York.
We just said about you saving the ICB money, by the way. Technically, it should be an ICB.
It's usually an ICB for
we occasionally pick that up. And at the
Of which we're very grateful, Michelle.
Yeah. Okay, adult secure. So we've reduced, as mentioned, from 181 to 140. This excludes our high secure population, of which there are 8, and they're at Rampton.
Yeah.
That is still nationally commissioned by NHS England.
Yeah.
We have expanded our community forensic services. So the collaborative took a calculated risk, I would say, right at the very start, because we'd been given some money by NHS England for community forensic, but NHS England, that ceased at a certain point. We decided to invest in that, and we were able to reduce the number of people in hospital and utilise that money to invest in the community forensic team. There are now more people supported by the community forensic team than there are in hospital for adult secure. Now, a lot of people think, oh, they go to community forensic and it's a £500,000 a year package in the community. No, that is not always the case. Most people go home. It's an interesting concept. They go home.
Yeah.
So I just want to myth bust that one today. We're doing a lot of work around women's pathway transformation. A lot of our women have not just been perpetrators of an offence, but they are victims. So we're partnering with a charity to do work with women while they're in secure services, because a lot of time women struggle on discharge because they are victims. Our clinical ready for discharge statistic numbers have reduced, as shown, and we do a lot of work with the criminal justice. And can I say, as at this moment in time, we're on the good step with criminal justice because we're not breaching the prison transfer new rules that have come in. We are one of the few areas that's actually managing that, which is really good. Thanks, Emma. So this is my exciting bit. I'm sorry, I get very excited about everything, but this particularly. So children and young people's mental health. So following COVID, we just saw a tsunami of referrals into services, particularly for young people with eating disorders. So what we did was we reviewed what provision we needed, how we were going to prevent hospital admissions, and we developed the eating disorders intensive treatment service across Humberside. That service alone has prevented 57 admissions in the last 15 months into children's mental health services. We also did a lot of work around nasogastric feed at both Mill Lodge and Inspire. And we, Q1 2024, we were doing 548 feeds at both units. That's to not 548 children, it's 548 feeds. Q1 this year, 3. Now, we don't send any children with eating disorder out of areas, so it's not like we've just stopped doing it in these units, but we send them out of area. We just don't have any kids out there with eating disorder either. We've done so much work with the paediatrics and the acute hospitals regarding the inappropriate use of NG feeds. And we've had national recognition around our work around eating disorders and children, young people. I've been asked to by NHS Wales. I've been down there to Cardiff twice to present to them on the work that we've done. We're regularly being asked by NHS England to showcase the work that we're doing across around eating disorders and young people. And as I say, we've gone from 18 out of area to 6 out of area, and that's only purely because we just don't provide those services in our area.
Hugely impressive, that.
Yeah. Budget, financial, our budget allocation is 67.2 million. We have a favourable end of year financial position, but we've prioritised that money for reinvestment into more services to prevent more people being accessing hospital and being able to maintain at home. Learning disability and autism, over 20 people have discharged from Secure since 2021, and we've actually used some of that savings of funding to invest in services within the Humber and North Yorkshire area, so a new occupational therapy post within North Yorkshire and York. And we're now looking at doing some work around children's learning disability and autism in North Yorkshire and York. Thanks, Emma. So looking ahead, our priorities, we want to do more around the whole pathway, particularly around eating disorders, because eating disorders in the community is very few low numbers. and in hospital is low numbers, and those pathways are really, we want them to make them more seamless. Develop further alternatives to admission. So we're currently working with a lot of our service users about, so you've had experience with alternative admission, how could we make it better? What could we do differently? Reduce the inequalities. So as I say, we have done a lot of work around rolling out autism-informed care over the last 18 months, because we used to unfortunately have to send young people out there for autism. We don't have to do that, but we know we need to improve on that further. More care closer to home. Pathway optimisation. So that's more around what resources have we got and how do we use them even better.
Yeah.
And then the big one for us is the implementation of the Children and People's Mental Health Development and Spec, which specialised provider collaboratives are expected by NHS England to lead on. And we have to submit a service development improvement plan to NHS England, which we've just done. And we've already had feedback from NHS England that they're absolutely really happy with what we've done already, which is really good. But we are working with all our partners, ICB, social care and education, on development of that spec. It's quite a weighty document if anyone's had time to read it. It's quite a big document. And then just the last two bits I wanted to share, and I think it's really pertinent actually from what you were just discussing at the previous agenda item. We do take everything, feedback, we take it, criticism, good, bad, or everything. But these are just a few I wanted to share with you. So these are from 2 young people from our eating disorders intensive treatment service saying thank you. A lot of our service users are really creative, got a lot of really good poets. So we often get poetry in from service users, which is really lovely. And the next one, please, Emma. So you might not be able to read this clearly, but this is from a service user who thanked us after the Shern clinic was closed and we safely transferred them out of services. And the young lady's basically put, she's happy for us to share the names, it's fine, I've got permission for all of this. She said this to the case manager, Helen, in the nicest possible way, I hope I never see you again. That was lovely.
What can you ask for?
Absolutely.
I mean, a huge thank you, Mel. I kind of think this is really kind of why I want to start with the whole principles of collaboration is that actually we can do so much more by working together. And I kind of think this is a particularly complex area of work, but actually being able to deliver this range of services to actually really kind of drive forward that whole principles around care close to home, around what's the alternative model we can get, what's the focus on patient outcomes, getting your feedback, which is I don't want to see you say it over again, is a real testament to kind of the quality of this work. And actually that national recognition of the stuff that is happening here through the leadership that you have taken with this, that the collaborative has kind of taken through the stewardship of Humber, I think this is a huge success story. And if you take away the specialist element, you think about what is the opportunity, what are the principles of partnership that enable us to take some different approaches, which is very different from what we were doing when you and I first worked together, Mel, all those years ago. We weren't doing this stuff. We were doing old style stuff that wasn't getting the outcomes this does. Actually, that takes leadership, it takes vision, it takes commitment of clear vision as to what you're going to do. This actually, and having seen Rarian Fields when we were there last week, to be on a unit that didn't feel like a unit, actually felt therapeutic, focused on recovery rather than treatment, that is a massive thing. And I kind of think there's a huge thank you to you and a huge recognition of everything that you and the team have achieved. Michelle, do you want to come in with something?
No, I'm sorry, I didn't actually, but since you've asked me, I will. Just obviously
Never say no, Michelle.
But I think for me, it's the principles of what we've done and what we constantly share with NHS England and other partners and other ICBs, actually, not just around the specialist commissioning piece, but how that can be scaled up within a particular role. So we have worked quite closely with some of the ICBs that assess with their mental health piece in general. Because what we have to be careful of is when we start to develop future models around that home-based treatment, that's an ICB responsibility.
Yeah.
So even though we've already taken on board some of that, we've still got a specialist commissioning budget that's used for that specialist commissioning piece. But what other ICBs are coming to it and saying is that, can we join it together? Yeah. So I think we've demonstrated it can be scaled up. So, and I think the reason why it works, people say, why does it work? I think it's because it's led by providers.
Yeah.
Disrespect people like strategic commissioning, absolutely. But I think because it's led by providers, we sort our own issues out.
Yes, absolutely, 100%. And it's amazing to see when we first started on the journey. The providers were all really up for it and wanted to do something, but there was obviously nervousness because they'd not worked in that way before. But
No.
Over a period of time, you've just got such clear collaboration around all of them and trust. I think that's the big thing, is the trust is there. And even though Leeds York Partnership isn't on our patch, but when we were in difficulty, just to phone Leeds up and say, Sherwood Clinic's closing, we haven't got any beds. And they were like, it's absolutely fine. What do you need us for? Modern Matron's going to ring your clinical director in a minute and we'll sort it out.
Yeah.
It's that trust.
It is. And I think there's something you defined as well, then, Michelle, which is about grey areas. So there's lots of grey areas in the future model of working. Grey areas are either really scary or the massive opportunity. And actually, I kind of think we just need to know they're there, and actually how we negotiate that and how we work together in those grey areas is some of kind of what is happening here. Are there any questions of time? Any immediate kind of questions for Mel and Michelle? And this is, if you haven't got the report, make sure you do, because it really is a fantastic read. This is something I know that you shout about, because actually nobody else is doing some of this stuff, and we are leading the field. I'm very proud of that. So,
it's an observation, really, and it's the passion and the energy and the commitment oozes out. And I think that cannot be underestimated in developing the relationships that stand pressure. And so, you've engaged everybody and it's really clear you care. And so for me, it goes beyond collaboration. What I heard a lot of is peer-to-peer respect, that learning from each other, which is not a construct of a requirement to collaborate. It's an engagement and a willingness. And I think that your whole approach is embodied in that energy and that passion and that commitment.
And a lot to learn from here. So I think that's incredibly important. Thank you both for that. That is really, really fantastic. And I kind of think you've set the bar very high in terms of collaboratives.
Thank you.
Thank you. I shall see you seem to be far too long, Mel Bradbury. Well, I lived together about years ago. One of us is aged better, and it's not me. So, Lynn. So, just to say, the collaborative acute providers is very different, and actually, very much in terms of that first step approach as to how our acute providers kind of came together. We've seen the report, so unless you've got some slides you want to share with them, I think there is something for me about touching on, Lynn, what the acute collaborative has kind of achieved together, because I kind of think there's some real tangible stuff in there. And then also, I suppose, just your thoughts about what that vision for the collaborative moving forward is in the new world. Because actually, acute is incredibly important to us, and the opportunity we have with our acutes working together is really, really valuable. So over to you, Lynn.
Okay, thank you. So I'm going to be really brief. And say that you've got the annual report. It's fairly clear. I'm not intending to page turn on that, but pull a couple of things out. So it describes a comprehensive overview of what we've been doing in the last 12 months. I haven't been on the patch for that length of time, so can only say that I've worked with the collaborative more closely in the last 6 months. It describes who we are, because I think that's really important in setting the scene. It gives some information on geography and numbers, because you can put that into the context of the environment within which we're working. And then there are some success criteria, which are, some snapshots of success, which are highlighted in the report. And while I'm not going to repeat them, I don't think we should play those down. They are actually quite seminal in terms of the changes. So, there's the cataract work around the single point of access. There's a day case surgery work around laparoscopies, which is, fantastic in terms of moving the dial and turning the numbers up. There's a CDC access, and then there's a few case studies in there. And the one I particularly liked was the AI one with the MSK service with detection. So I think that is all really good. It moves through the report then and talks about championing collaboration between the acute providers. And it's not a case that people don't want to do that. Sometimes it's just at the end of the list, or it comes to the fore when there's a problem. But being much more proactive rather than reactive, I think, is the way forward. So again, it gives you some examples there about the elective network, about the orthopaedic network, and how we're advancing those. But that's all contained within the report, and I'm happy to pick up on any specifics. What I think is more important is to talk about the next steps and the objective for 26-27. So we will continue to work on bringing together the communities of practice. We'll continue to learn from each other and the best practice, and we're promulgating that much more as we move forward, Jason. But I think what is important is for you to be aware that we are considering widening the provider collaborative, so it doesn't just become a collaboration of acute providers, but is something that's much more system-wide. And we had a discussion earlier part of the week to see if colleagues wanted to join us. So that was our ambulance trust. It was the mental health trust, etc. We haven't gone particularly wide on that because I think we could end up replicating some of the work that the ICB does, and we haven't got the expertise to do that, nor should we attempt to do that. But working together as a collaborative, I think there's a real space that we could fill. So if Teresa asks for a response to something, we can do that. You're transforming services. We can do that as a collective as well as individual organisations, but it becomes quite powerful. I also think it enables us to understand each other a lot more. So it avoids this, blame culture if something isn't happening. Well, it's X or it's Y organisation. It's not, it's a combination of things, but fully understanding the services that we offer, if you like, some of the pressures that we're under, supporting each other, which always happens in a reactive circumstance, but doing that more proactively would be good. And I think it could become a real powerhouse to do quite a lot of the collective response work. That's how we did it in North East and North Cumbria. We had a number of SROs on a number of things, and I cited the example when capital is tough. We had from the ICB a request that we look at how we divide the capital allocation across the providers, and painstakingly hard, but we came up with a set of recommendations which went back into the ICB board and was approved. So there's some real good examples we could pull on to utilise within that forum, but it's early days for us and we'll see how that goes. There was a positive support in terms of continuing those discussions. So that's a real whistle stop tour with the previous report and where we intend to go.
Thanks, Lynn.
I should just say, and I know that you've said this before, Jason, that we do not receive funding now. This is funded through the providers themselves in terms of supporting this work.
Yes, it was our gift to you for Christmas.
It certainly was. It certainly was.
Yes, but we wrapped it nicely and gave you a bow.
You did.
We did. So, I mean, I think there's a couple of interesting things. I think you said that, Lynn. I think one of which is around that touch point with providers in whatever configuration is really important. And I kind of think you've described a collaborative that is based on something proactive rather than reactive. And actually, I think some of what was being described, I think, by Mel in the specialist mental health bit was around the opportunity to do the right things and to do some things that would benefit rather than things that had to happen because the knee was jerking. And I think there's a real kind of evidence base there in terms of that. I think it would be useful to see where we next go with acute and the fact that actually acute has a lot to do at the moment, it feels like, and there's a lot of focus on acute. Finding the space to have conversations which are about development and around new stuff rather than just hamster wheel of what we're having to do today feels like that's an important space to be having, because actually, if the 10-year plan is right, it tells us it redefines the roles of hospitals, but roles of hospitals have to be different to where they are now. And actually, where that conversation takes place across a wider provider community, having the space to do that, whatever we call it, is important. So I would personally really support everything you've said about that future direction of travel. And also, just a feedback to Wendy and the team, appreciation for the amount of work that the CAP has done at a point where acute has probably been at its most challenged. The fact that there are some real tangible stuff in this report is testament to the work of that collaborative and the people kind of working within it. So if we can feed that back and I've personally gone back to Wendy already. If you can feed that back on behalf of the board, that would be really helpful then. Anything else for Lynn? Sue's very engaged with the collaboratives.
Yeah, well, I found both. The reports were easy reads. There was lots of information in them. They were engaging, which isn't always the case. But question I had specifically was, whilst there's lots of improvements and lots of increased activity, how do you determine what your work plan is going forward, aligned with the areas that are not showing improvement when you look at constitutional standards? Because there is a bit for me around a lot of the elements that have improved. We're struggling to map them across to some of the pathway and the constitutional standard elements. And the
stuff that's in the next report.
Yeah, and so it's just understanding, I suppose, in your thinking, and as you said, it's new and it's it's growing. How you'll determine what your work plan will be, aligned to those areas that have been really difficult to shift sustainably.
Okay, so I think we have to remember we're a group of individual organisations that will come together and, if you like, we should make the changes around key priorities. I don't think we can insist that it's around constitutional standards. It would be a bit silly not to do that, but it's what emerges from that discussion. What's in the work plan? And we do engage with our chairs through this process, so they'll be able to influence it. But it's not a case of saying on the constitutional standards, elective care, UEC, cancer, this is what we will focus on, because colleagues can say, well, I don't want to participate in that, and we'll just look at that from an individual organisation. So I suppose what I'm saying, Sue, is there's that bringing together and the meeting of the minds, that this is, you get the greatest synergy by working together and sharing the good practice and looking at that. But I don't think it can be driven by any one organisation. It's got to be, wouldn't it be helpful if we looked at X, and the benefits to doing that would be Y? Because, like I say, they can walk away from the collaborative and say, that's not for me. I really don't want to focus on counselling. I'd much rather focus on diagnostics, and we can't get the meeting of the minds. So we've got to do that real collective understanding leadership piece together first. And I think we've got a platform to do that, but I'm not sure that that's been capitalised on in the past.
And I think it's important.
It's really important when I'm going to be quite honest, when the ICB were putting funding in, I think it was quite easy to say, oh, we want to look at X. I think there was a disengagement across partner organisations in the CAP at that time. So if there were no other ideas coming forward, they would coalesce around what the ICB had said or what a particular organisation had said. This is a completely different approach.
Yeah.
I think it will be the constitutional standards. I can't see it being anything else, but I'm not going to promise something that the work plan could then come up with something that's different, because that will be for the providers to determine.
Yeah. And I think there's an important distinction here between organisations and the collaborative.
Yeah.
And I think there's a really important distinction in terms of the space to go, what's the thing we're all interested in that we might want to do something about? And actually that could be workforce, it could be digital, it could be... It could be letters, sending out letters to people, couldn't it? It could be all of those things. So I'm going to bring Michelle. I'm just very conscious of time. I want to finish at latest in 10 minutes. We've got quite a bit to go through. So I'm just going to put that out there. Michelle.
Apologies, and that's to take an urgent call. So Shane will run with the new partnership approach to the collaborative.
Yes.
Yeah. I mean, obviously, I completely endorse what she said, along with my other chief exec colleagues, which I'm sure they. I think from an NHS constitutional standards, we have to meet the NHS constitutional standards. So I think that would be a given within the parameters. And I think it's up to the providers in a way to determine what it is that we want to look at, both within the contractual situation that we've got and how we want to pursue that. And so I think for me, we've been talking about the providers coming together for a while. Not just because of the changes in the ICB, but because the providers collaboratives were quite siloed and quite islands, and we just needed to bring those together because of the mental health and the physical health, and obviously we've got community services, etc. So it's a bit about some of the things we always talk here on duplication, variation, standardisation, core, and again it goes back to Mel's presentation that collectively together we should be able to do that. We should be able to work on some fairly big ticket items which we've already started to explore. And also sometimes how we collectively respond to some other things from an ICB point of view. And positively. So I think for me, and we've had our first meeting and we've been talking about it for a while. I think it should be, and I think the ICB should use it in that format, in that way as well as a conduit as well.
Okay, I think that's really helpful. So thank you, huge amounts, Lynn, for the work that's been done here. And I think for that snapshot vision of kind of what the future, and I think it is quite exciting. I kind of think the opportunity people have by coming together, whatever that composition, if that's acute, if that's widely acute, whatever, I think that's where the magic happens. That's where the stuff that kind of starts to kind of generate what could we do differently and what are you doing over there? I think we touched on that a couple of times all the way through the meeting. Has been the first start to any of this is the curiosity to what we have already. Because actually we are probably better off than we think we are. And then how do we learn from each other? You described that peer relationship before, and I think very much that peer way of working is the thing that brings about change and learning in an organisation. So huge thank you, and thank you to Wendy and the team. So we're going to thank you. So we're going to touch on. So Sean, you've joined us. Is your camera working today? Yes, it is. It is. If it wasn't, we've got IT in the room. So if your camera wasn't working, I could have accessed IT support for you. So this simply, Sean, and thank you for covering for Sean today. So I think this is just the headlines in terms of the performance report, and there is some changes in terms of how this is starting to evolve in terms of how it's presented, which I really kind of welcome. I think we set the challenge a while ago to say, let's find a way to present this information in a way that's accessible and tells the story rather than post those slides with percentages that don't relate to anything else. Thank you, huge amounts for doing that. I think we touch on the headlines now, and I think we have the opportunity in part two to probably have the discussion we want to do, which kind of takes us into some of the detail around this. So if we can just do headlines, if that's okay, Sean, and then we can have a date with you later on.
Yeah, that's fine. So I won't pull it up the report now and go through it page by page. You have obviously got access to it from the pack that's gone out. So what we've tried to do is, and I don't think for a second this is a finished version. I'm continuing to work with directors and the non-exec directors, and I've met Sue since we last met to look at the format of this and how we're getting it right. I do think there's the conversation I heard earlier on around us being a strategic commissioner. There is something about this report and whether going forward we need to be more strategic rather than month on month. But headlines in terms of this month, in terms of the report, are with the latest data available, published and unpublished, and the report itself, the charts are based on published, but the commentary that goes with it includes unpublished, up-to-date information that hopefully the board can see. What we're trying to do there is that we at Q1 we are currently away from the performance trajectories in the planning round for a number of the key indicators, and some of them we are some way away. And I would say in terms of planned care, the waiting list size took a growth in month one that was larger than what we'd seen over the previous 4 years of reporting. It was the single biggest growth in the waiting list. So planned care waiting list growth is a worry to me. 4 hours were away from plan. That's the urgent care. We saw an improvement in March and April, but in May and unpublished data for June is showing that we're not seeing that sustained increase that we saw in 4-hour performance. Cancer FDS is not where it needs to be in terms of the faster diagnosis. So in terms of the secondary care measures, the big ones that hit the radar of national, we're away from where we need to be, either in the published data or the unpublished data. And then what goes hand in hand with that is the trajectories improve. The ask is to improve performance right through to year end. And in most of those indicators I've just described, we're seeing variable delivery. So we're not seeing any sustained improvement. So right now in July, even though the reports charts are talking about published data, that's what's in them, the commentary adds to it to say unpublished data and the trend is not showing at this point that we're on track to deliver our year-end ask. The only other thing that I want to say in terms of secondary care is some of the indicators locally within the region and nationally, and it does vary by provider, what I'm about to say, some of the causes for that performance is linked to demand increases. So certainly 4-hour performance, we're seeing nationally and locally record A&E attendance numbers. And in terms of planned care, anecdotally, because I don't get GP referral data, we're anecdotally been told of GP referral increases. Now, the proxy that I have for that are additions to list. They're called new clock starts, but basically it's new people being added to the waiting list. I can see that number, and whilst I do see some patterns of growth, certainly in April, it varies by the month. May numbers were different, and it varies by provider. So it's not as uniform as saying, oh, A&E attendances are up and all GP referrals are up. I'm working on getting to grips with that demand piece, but certainly nationally, it is part of the narrative that we're hearing. So away from plan from where we need to be at Q1, published and unpublished, and the trajectories that we need to see improvement on, we're not necessarily seeing them at the rate that we need, and further work needs to be looked at the demand piece. And then finally, out of hospital, primary care performance looks well. Community services are off track in delivery, but they're still showing improving trends. So at this stage, I'm not saying that those numbers are not going to come back to plan in year. And mental health is mixed in terms of the key indicators. We are certainly seeing some areas with improvement, some areas of delivery, and there are some indicators that are off track at Q1. So that's a summary of the headlines that are in the paper.
That's really helpful, Sean. And I think they're the headlines we pick up in part 2. And I kind of think there are no doubt lots of questions in board members' heads around just understanding some of those peaks and troughs, and actually some of that what's happened over the past 2 months. I mean, it's been quite an interesting period the past 2 months. There's some really good news around aspects of mental health and some really good news around primary care, which then reflects back to positivity of some of the primary care survey stuff as well. So we'll pick up any detail about the money in the second part. Anything you want to say headline, Des, in terms of the money?
Sure. Just really quickly, Chair, just to say that we are, as of this report, still reporting deficit linked to the fact that we hadn't had deficit support funding.
Which will balance everything out.
It will balance out, not in month 3, because we have now got the assurance that we will be getting the money. We've got confirmation we will be getting the money from for quarters 1 and 2, but that will only come through in July. So we will only start seeing it from month
in July.
Yep.
Okay.
That was all I wanted to say.
Okay, so and thank you to the board, and the amount of time that went into the minute we had to record last time was huge, wasn't it? We got there in the end. Anything? I mean, we can pick up Michelle. I think in terms of the quality bit, or can we? Is there? Okay, super. And then we no longer report the workforce stuff to be doing because it's no longer our responsibility. So if you were hoping for workforce, you'll be disappointed because we're not going to get it. But we are going to get some of Jane now. So Jane,
I'm going to do the man review in 3 minutes. That is a pretty challenging task. So you've got
a little bit longer because only got inside the pulse afterwards. So yeah, that's really, I'm not saying take an hour.
I would have taken longer, yes.
Yeah. So I'm saying if we could do this justice, rather than excessive justice.
Challenge taken. So you have a paper in front of you. You'll remember that I mentioned last time when we met in private that the Lord Mann review had been published at the beginning of June. You've got links in the paper to be able to see the detail of that. You've got the appendices that shows all 32 of the actions. That's not though what's coming to the board today. You can look at it at your leisure, obviously, but that's not what I'm tasked with asking you today. There are some particular requirements that were in the Lord Mann review for boards to consider with a response date of the 31st of July for us to submit that consideration. So in the paper that you've got in front of you, there are a number of things that we've been asked to, there's a number of recommendations for us to consider. The first one is that you note the Lord Mann review. I think that's relatively straightforward because you've got that attached to you. That we've said when we've looked at it internally, and we do have our own staff network, and I will just very briefly reference as part of this the work that we've done around the Inclusion Assembly, which will no longer be led by the ICB going forward. In fact, Michelle Karen's leading that on behalf of the system. But I think there's some really important work that assembly can pick up on the back of the Mann review. And to remind you, we've developed the vision, the values, and the behaviours for that Inclusion Assembly already, and released what we call our heart approach to the way that we're doing things. And I can circulate that for those of you that haven't seen it. And we've just recently, as we've lost our internal ICB EDI lead through voluntary redundancy, I'd like to actually say particularly thank you to Rachel McCafferty actually for setting up the Assembly and getting us to this point. She's done some fabulous work, but her leaving gift was the allyship and advocacy training and actually training the trainers to be able to do that across the system. I mention all of that. I know it's not in the paper, but it's a really important vehicle, I think, for us to be able to have some consistency in the way that we approach things that are in the Mann review. Notwithstanding that, we've been asked to look at, and we've assessed internally, that we'll manage the majority of what's come through the Lord Mann review through policy development, but working with our staff network internally as well. You have been asked as part of this to confirm that you will sign up to the NHS Race and Health Observatory 7 anti-racism principles. You've been asked that we would make a decision on adopting both the IHRA definition of anti-Semitism and the government definition of anti-Muslim hostility. And if you do support that, that we'll confirm that to NHS England nationally by the 31st of July. We will have further work to do when we run the staff survey later to make sure that the board fully understands the staff survey data and with particular regard to the topics that are in the Lord Mann review. But there's a lot more to our understanding of the staff survey than that. And that we will make sure that we pick up all the other elements as and when they become available, because there's a lot of things that will come in time, like board racism training. We did a lot of work ourselves as a board pre our new model last week with Diversity Scotland, which was incredibly helpful, and they supported the Inclusion Assembly as well, actually, in developing the behaviours and the vision and the values that they're working to. So that's what we've been asked to do today. I'll stop at that point. I could keep going, but I won't.
No, that's really helpful, and I think really welcome the idea about we do need to revisit the work that we do as a board and as an organisation, which is about diversity and inclusion, and actually how we incorporate stuff, and actually how we do something which is very much more experiential in how we kind of work. And I think this is a really important kind of moment for us in terms of how we approach those issues. So for those of you who may have done the online training on equality and diversity, thank you. But I do think that training and actually that piece of development work as a board is something that we need to do together collectively rather than necessarily something online, where it all depends on whether you can explore 80% at the end. Which doesn't feel the way to do that. So just a touch point with the board. So we're noting, and we've already had flagged to us the Mann review previously. Actually, what we talked about is very much that idea of the localised kind of action plans, the piece of work I think you're describing, Jane, which has happened internally, which has said we can manage quite a bit of this through policy, but there are other bits and pieces of work we need to do, but we've got a lot of mechanisms. And actually some of what I'm interested in the Inclusion Assembly bit is that's very much a system bit. So actually what's the opportunity system to do some stuff around Man rather than isolation. just check with the board our commitment to the principles, the principles of the NHS rates and the Health Observatory, which are there with that. And that we will, I guess it's a given that we will undertake the new anti-racism training when it becomes available. I think that's part of our wider kind of offer. And staff survey data, I think, kind of gives us anyway actions that we need to take. I think some of that may have to do with things and stuff that's in with MAM. And actually, the important bit, I think, here is like definitions, adopting those definitions. So we've got a shared understanding, a shared definition rather than operating different ways. Is there anything in there which the board feels they couldn't support? Okay, and thank you. And you might work and to echo those comments about Rachel Cafferty. I mean, we are lucky to have had that opportunity. And thank you, Michelle, for agreeing to host that on behalf of the system. And it's really important that somebody can move the assembly and continue to host it and move it forward. So the next bit are the insights reports for your information, which is the bits from committees. Thank you to all of the chairs who have navigated their first insights reports. There's a knack to them, but I do think they're really informative. And I think it's a real assurance from the board around the work that's happening within those committees, which is really important. You've got the link to the good news briefings, the absolute information, it's there. Know any of the business. I think it's been a really, really interesting meeting this morning. We've kind of brought together our thoughts about being a strategic commissioning organisation, a huge emphasis on patient experience and views of patients, the huge opportunities we create through things like neighbourhood health and our future commissioning, but a recognition that commissioning and contracting are one part of the puzzle, but actually some of the work, which I think Lynn's touched on in describing the whole thing around how do we have proactive conversations about the things we might do together rather than actually relying on a safety net. I think some of this stuff is stuff that we need to be doing. Next meeting in public is 16th September. There's already an agenda that's kind of mounting for it. I kind of think we've been set a challenge today, which is around how do we make sure that health and equality is everybody's business, incorporating everything we've done. And actually, how do we take the Big Biggest Kills report into something which is more than a report, but actually is the way that we kind of work together on our shared commitment to the things that make the biggest difference in our communities. At this point, I'm going to resolve to exclude press members to the public from the remainder of this meeting. Thank you for joining us today. Thank you for what feels like a very exciting kind of positive kind of conversation moving forward in a room which is rapidly heating up. And we will see each other in September. And thanks very much. And thank you for your interest in our work.